Hello, everyone. I'm Muriel Finkel, and on behalf of the Amyloidosis Support Groups, we want to welcome you to our ATTR Amyloidosis webinar. We are hoping to resume a few in-person events in 2023. We're waiting for the okay from the hospitals that host our events. We recently did a survey on resuming the every other year ATTR event in Chicago, and we'll be letting you know about the results of that survey really soon. If you're on our mailing list or you've joined our Facebook groups, you'll be notified about all of these events. They'll also be up on our website, amyloidosissupport.org. For this webinar, you will not be able to post comments in the chat. Paula will be posting links and other valuable information in the chat section, and we'll explain how you can save that chat and refer to it at a later time. Speaking of Paula, in the control room, we have ASG's Executive Director, Paula Schmidt.
Hi, everybody.
And our Special Projects Director, Bob Gibson.
Good afternoon, everybody.
We appreciate your emailing in your questions, and they will be answered by our panel sometime today. We have quite a few of them. If we run out of time, we'll get them answered and the responses emailed to you. Our presenters today are cardiologist Dr. Rick Ruberg from the Boston University Amyloidosis Center, Dr. Jignesh Patel from Cedars-Sinai in Los Angeles, and neurologist Dr. Chafic Karam from the University of Pennsylvania. All of these doctors and all of our guests are giving up their Saturday for us, and I know you join me in saying thank you to all of them for doing that for us. All three of our guest doctors today have been to our live events more than once, and we do appreciate they're always willing to support our patients. We'll also hear from Intellia's Michael Maitland, Alnylam's Colleen Moffitt, Ionis's Gustavo Buchele, Pfizer's Craig Spolsky, Chris Olson, and Joe Shuck. They come armed and ready, right? And from the University of Tennessee, Dr. Jonathan Wall. There'll be a quick survey when this meeting is over, and we ask that you please take the time to fill it out. Should you have to leave early, we ask that you fill it out when you leave. It's important to us, and it helps us in developing future webinars. We're going to be referencing treatments today that can be seen on our treatment chart, and Bob will be putting it up there so you can take a picture of it or print your screen. You can also feel free to email me at muriel@amyloidosissupport.org for a copy, so you don't have to wonder how to spell any of the treatments that we'll be referring to today. Now, we're going to hear from Dr. Rick Ruberg, who will fill us in on treatments for those with cardiac involvement. Dr. Ruberg.
Thank you so much, Muriel. I'm going to share my screen now. Hopefully this will go smoothly. Okay, everyone should see my screen. Can I just get a confirmation on that from Bob, please?
Looks good.
Great, thank you all. It is a pleasure to be here with you all today. And when Muriel asks, I always say yes. And I do hope we can have an in-person webinar, in-person seminar again soon. Those meetings are just so meaningful to me to physically be in a space with all of you and to talk to you and hear your questions in person. There's really no substitute for that. But this is kind of the best we can do. I hope that you are all in a cool place. We were kind of talking before the webinar started about the heat wave in the United States and Europe now. And so at least I can say I hope you're in some air conditioning, and for the next couple of hours, you'll be cool and we can answer your questions. So I'm going to spend the next 20 minutes talking about cardiac amyloidosis from ATTR. And the first part of my presentation is going to be a little bit about amyloid, so we're all on the same page, obviously a huge topic. And the second part of my presentation is going to be specifically about the therapies that are available, all of which were just shown to you on the screen that Bob put up about the guide for therapies. This is a really kind of a 10,000-foot view not down in the specifics, but I'm certainly happy to answer the questions that you might have in the Q&A. After this, you'll hear from my colleague, Dr. Patel at Cedars-Sinai, who will talk more specifically about treatment of congestive heart failure symptoms and also management of advanced heart failure, which is his specialty, and he's world-renowned in that. So let's just start with amyloid and amyloidosis. What's the difference? What is amyloid? Amyloid is a protein folding problem. I think you all know that. And the protein that misfolds causes this thing called amyloid. And amyloidosis is the disease that results from the proteins that are deposited. And all amyloid diseases are unified by the fact that they are misfolded protein problems. And what does that mean? So this is a cartoon from a medical publication showing the production of a protein using the cellular machinery. And the proteins fold. We make tens of thousands of proteins, and these proteins all have to fold right. And when they fold right, they have a function. But sometimes they misfold. And when they misfold, they can sometimes form these aggregates. They come together, and when they aggregate in a certain form, a certain orientation, we call them amyloid fibrils. And that's what amyloidosis is. It's a problem with protein folding. The problem, and why is that a problem? Well, when these proteins misfold, not only do they not function normally, but they also deposit in solid organs. They deposit in these organs like the heart or the kidney, and they cause those organs to malfunction. And that is what amyloidosis is. There are over 35 different proteins that can misfold, and we describe them as A for amyloid plus an abbreviation of the protein that misfolds. So ATTR is amyloid from TTR, or transthyretin, which we'll talk about in a minute. So there's a lot of proteins out there. And I want to also point out that amyloid diseases are similar to, but distinct from, Alzheimer's dementia. We've all heard about Alzheimer's. The government's investing billions of dollars in trying to solve it. Most of us have been touched by Alzheimer's disease because it's so common in our families. But in Alzheimer's dementia, the protein that misfolds, it's a protein folding problem, is in the brain only, and that's called amyloid beta. And in the systemic amyloidoses, ATTR, AL, AA, the proteins don't cross that blood-brain barrier, and they're different proteins. But the pathway is still kind of the same, where you've got a misfolded protein that causes cellular dysfunction and injury. This is what a heart biopsy looks like with amyloid. And amyloid takes up a characteristic stain called Congo red. And there's a whole story associated with Congo red that I don't have time to get into. But this heart biopsy specimen has these red areas here. This is under the microscope, using a plain microscope with staining. And this is what amyloid looks like. And under the electron microscope, when you zoom in 1,000-fold, you see these fibrils, or these like stick-like structures. And this is what amyloid proteins look like under the electron microscope. And they deposit around heart cells. And when they deposit around heart cells like this is a different specimen, a different heart biopsy, showing heart cells here, kind of the purple, and the light purple here, almost pink-like, are amyloid deposits. It causes the heart to become thicker. You can imagine, as these deposits kind of go in between the heart cells, the heart gets thicker, but it also gets stiffer, because the heart has a normal compliance, a normal stretchiness. And when amyloid deposits in the heart, that stretchiness gets messed up, and that causes stiffening of the heart, which leads to something called diastolic dysfunction and ultimately restriction. Again, we don't need to go into those details, but the problem is that this amyloid, not only does it cause the heart to become thicker and stiffer, but it directly injures the heart cells itself. And this is the problem. If we can get rid of this, we can talk about therapies for that, or if we can at least stop this from being made, the heart theoretically can repair itself and to some degree and get better. Now, let's talk a little bit more about transthyretin, or TTR. It's also known as prealbumin. Many you will see that we test your blood for prealbumin, and this is the same thing as TTR. Same protein, different name, but it's the same thing. TTR takes its name from trans-thyretin. Thi comes for thyroid hormone, and retin comes from retinol. Thyroid hormone, you all know about the thyroid. I think it's a gland in your neck. It produces a hormone that we need to regulate metabolism. TTR, this is a cartoon of TTR. It's got 4 identical but different colored, in this case, parts to it. They're called subunits. The thyroid hormone plugs into the side of the molecule here in this binding pocket. And vitamin A, or retinol, also binds there. And this is why, if you're taking a silencing medication, you're taking supplemental vitamin A, because TTR is the principal transport hormone for vitamin A in the blood. It's not the principal transport, molecule for thyroid hormone. There's a whole other molecule for that. So low levels of TTR in the blood, as we get with treatments for silencing TTR, don't really distort thyroid function, but they do interfere with the transportation of vitamin A, which is why supplementation is necessary. But this is what TTR looks like in kind of a cartoon form. It's got 4 subunits. You're going to see it again, and the thyroid binding sites are here. And that's important because 2 of the drugs we use to stabilize TTR and treat TTR bind to these sites into these pockets. That's tafamidis and diflunisal. So TTR is actually produced by the liver. This is really interesting. The liver makes TTR, but the liver itself isn't typically affected by ATTR amyloidosis. TTR amyloid deposits don't occur in the liver to any meaningful degree to cause liver dysfunction, unlike AL amyloidosis. We could talk about that later. But TTR is produced by the liver, and then, as I said, it exists as this tetramer, or 4, it's a medical term for 4 subunits. But what happens is this tetramer breaks apart, and once they break apart, they can misfold, and then they can develop into amyloid fibrils, those stick-like substances you saw under the electron microscope. When they deposit in the heart, they cause, as I showed you, diastolic dysfunction or restrictive cardiomyopathy. And as Dr. Karam will describe to you later, they can also cause a polyneuropathy, an autonomic neuropathy, or a peripheral neuropathy. And again, that's not my area of expertise. I know a little bit about it, enough to be dangerous, but but that's not my area of expertise, and he's going to talk about that. But the interesting thing is that it causes both of these problems. In some people, it causes mostly neuropathy in other people, and it causes mostly cardiomyopathy in other people. And we're going to talk about that because that distinction is critical for how drugs are labeled for therapy. Why does TTR misfold? I wish I knew the answer to that question. We know a little bit more in inherited TTR, and we're going to talk about that in the next few slides. What is inherited TTR? Or hereditary ATTR? Well, this is because a variant in the gene structure for TTR has been inherited from parent to child, and that causes a change in the protein structure of TTR. As I'll show you, genes dictate the protein structure, and that leads to or creates conditions that favor the destabilization of TTR and facilitates misfolding and amyloid production. That's hereditary amyloidosis, and I think we have a pretty good understanding of at least a significant contributor. It's not the whole story, obviously, and I say it's not the whole story because these hereditary variants exist from birth. I mean, you're born if you have hereditary amyloidosis with the protein. Why do some people only have expression of their amyloidosis at age 65 or 70, but others have it at age 20 or 30? So there's a lot more about this that we don't understand. And again, we can talk a little bit about more in the Q&A, but we know that inheritance of the hereditary variant is a principal necessity for hereditary amyloidosis. Now, when the gene structure is normal, we call that wild type. Wild type. That's the genetic term. We don't know why people with wild type amyloidosis get ATTR wild type. If we did, I think we'd have a much better understanding. We do know that instability of the TTR protein is a critical component, which is why stabilizers work in ATTR wild-type amyloidosis. But we don't understand why it's associated with aging and why, if it's genetically normal, when people get to the age of 70 or 80, they start collecting amyloid in their hearts to a significant degree. We also don't understand why it seems to affect men more than women. We do know that as men get older, particularly in their 8th and 9th decade of life, the likelihood of developing ATTR wild type increases. Again, I could try to answer some of those questions in the Q&A, but a lot of this is just not known. Just kind of reviewing what I just said. So DNA is the basic building block of our cells. This is what our genetic code resides in. And DNA is translated into something called mRNA. And that's important to know because the treatments that we have actually work at destroying mRNA. We'll talk about that. And that mRNA is then translated. These are all scientific terms into a protein. So you could fix the problem by fixing the DNA, and there is a new therapy that does that. That's the Intellia therapeutic. We'll talk about that. You could attack it at the mRNA level, and that's what the TTR silencing agents do. The drugs that work with the antisense or small interfering RNA technologies. We'll talk about that. Or you could work at the protein level, and you could stabilize this protein and keep it from misfolding, and that's what drugs like tafamidis and diflunisal do, or acoramidis. And this is just an example of what a protein looks like in cartoon form. And when you have a hereditary variant, you get a shift in the amino acid, and one amino acid is enough to mess up the molecule. And that's what happens in hereditary amyloidosis. You have a shift in a single amino acid. You have one change actually in a single base pair in the DNA going back here. These are called base pairs. And that leads to a change in the amino acid, which then leads to instability of the protein. It's really, really powerful that one small problem in the billions of base pairs that you inherit leads to this such a devastating clinical problem. But we understand it much better now than we did, just a few years ago. And that allows us to develop rational therapies designed at where we know the problem is. The last thing I want to talk about in the science is heritability. And hereditary amyloidosis follows an autosomal dominant pattern. And this is really important to understand because this means that if a patient, in this case, a father, has an inherited variant on this blue chromosome here, in this case, this will be chromosome 18, ATTR, for example, and he produces children with an unaffected mother, there is a 50% chance that the children will get this blue chromosome and therefore inherit the allele that can cause amyloidosis. It doesn't mean they're going to develop amyloidosis, and that's called a genetic penetrance. And that's really important because there's a lot of people who inherit these variants but don't necessarily develop amyloidosis, at least in the time that they've been observed. Maybe if everybody lives to 100 or 120, that might happen, but obviously that's not necessarily going to happen. So my point of saying that is that the inheritance is really important, and that means identifying people has important implications for their siblings and their children. So I'm going to switch gears now and talk about what happens to the heart with amyloidosis. And this is an echocardiogram, a cardiac ultrasound, which most of the patients on this call have had, showing a normal heart and a heart with amyloidosis. And I told you that in ATTR amyloidosis, the heart gets thicker and stiffer. And you can see here, each one of these dots is 1 centimeter. And this is a normal heart. The wall thickness here is about 8 millimeters, so not even 1 centimeter. And the heart is squeezing normally. And this is a patient with hereditary amyloidosis. You can see here, this is a centimeter. This is more like 1.5 to 2 centimeters in thickness. So almost 50% to 100%, twice as thick actually as, 200% of thickness of this person. But the squeezing function is actually still normal. And that's kind of typical for amyloidosis, where this is called the ejection fraction is still normal, but the heart gets thick and this heart is very stiff. So this patient can have pretty significant symptoms of cardiomyopathy, even though the abnormality really is reflected in the thickening and not in, say, the squeezing function. So if you understand that, then you can begin to think about therapies for ATTR amyloidosis. So I've already alluded to them. Some of the therapies block TTR from being produced, and we call those TTR silencers. The principal ones that have been approved, I actually need to update this slide that I wrote a couple years ago. There's a new one called vutrisiran, but patisiran, inotersen, and vutrisiran block TTR synthesis. We'll talk about how that happens again. The stabilizers that have been approved, the only one that's actually approved is tafamidis. Diflunisal is approved, but not for ATTR amyloidosis, but it can be used off-label for that. And AG10, also known as acoramidis, is in clinical trial. And then agents that might remove the amyloid fibrils that exist are still in testing and haven't been FDA approved for that purpose. We're going to focus our attention on the drugs that have been approved, which are, and those that are in advanced stages of clinical trial, and this class is right here. But the approvals have really been fallen along kind of segregation sort of lines, cardiac versus neurological. So if you've got cardiac symptoms, you're not in as good of a place as you are if you have neurological symptoms in 2022 for having an array of available therapies. If you've got hereditary versus wild type, another big distinction. And this has to do with the way in which the original trials that demonstrated the efficacy of these drugs were designed. You're in a different place, and then cost and availability and patient preference by route of administration. In 2018, the New England Journal of Medicine published the 2 landmark trials that demonstrated, or pivotal trials, that demonstrated the efficacy of these 2 agents, patisiran and inotersen. And the representatives from these agents are going to talk at great length about these drugs later. These drugs both work through destroying the mRNA that makes TTR. And so they silence the production of TTR, and they do it through two ingenious strategies. One strategy uses small interfering RNA, and the other uses antisense oligodeoxynucleotides. And you don't really need to understand how that works, but just understand that each of these drugs are revolutionary in their therapeutics. And that's why I think in many ways they were both approved, because they're essentially not first in class because others had approvals, but among the first in class therapies for this specific problem. And we in the world of amyloidosis are grateful that these pharmaceutical companies chose to target hereditary amyloidosis, because it's a monogenic disease, meaning that the inheritance of this allele leads to a pretty simple problem that leads to complex manifestations. And the science was pretty strong that if you can stop the production of TTR, you probably could ameliorate the course of disease. And that's exactly what these clinical trials demonstrated. And that prompted the FDA to approve these therapies for hereditary amyloidosis with polyneuropathy. The TTR silencers are both injectable drugs. They're actually lipid, small fat particles that encapsulate these drugs that get delivered to the liver, and they turn off TTR production very effectively, almost 90%. So most patients have a residual, maybe 10% TTR production, usually with prealbumin levels that are around 4, 5, less than 10, based upon normal TTR levels, prealbumin levels, which were maybe 20, 30, or 40. And as I said, they use the cell's native machinery to turn off and destroy mRNA to make TTR. Again, really, really brilliant strategies. And the concept is that if you don't make TTR, you can't get worse. And so because you can't make any more amyloid. And that's not 100% true. There is a little bit of amyloid that theoretically could be made. But the studies really demonstrated a very impressive improvement in the neuropathy symptoms, and I'm sure Dr. Karam will talk about this, with therapy. Now, the drugs are reversible, so that means if you stop taking the drug over time, the TTR levels will return back to normal again, and therefore the disease could then progress. And so that's an important aspect of therapy. You have to repeatedly administer these drugs, and we'll talk about the administration. For the rest of a patient's life to maintain basically the improvement that you get with the therapy. And as I mentioned, the only approved therapies are for hereditary ATTR with polyneuropathy. If you have cardiomyopathy alone from hereditary amyloidosis, as is seen in the valine 122-isoleucine or V122I or V142I, all the same phenotype, then you're not going to be a candidate necessarily for these therapies, although we certainly try to administer them as much as we can because of their efficacy. But many patients with hereditary amyloidosis and cardiomyopathy only don't have appreciable neuropathy and are therefore not candidates in 2022 for these agents. And if you have wild-type amyloidosis, you cannot get these agents as of current approvals. As I mentioned, the RNA silencing therapies produced by Alnylam are patisiran, which is an intravenous injection every 3 weeks. So patients typically have an IV placed or an infusion line, and they have to go to an infusion center most typically to receive these medications. And the drug trial that demonstrated their approval was called the Apollo trial, and it looked at polyneuropathy principally, and the endpoint was a change in a neuropathy score. Patisiran is presently being studied in the Apollo B study for cardiomyopathy, and I believe those data are going to be presented at some point in the next couple of months. And again, you'll hear about that, I'm sure, in the Alnylam presentation. But obviously, we have great hope that if the drug worked for neuropathy, it should also work for cardiomyopathy with an acceptable degree of lack of side effects. And so we're anticipating the results of this therapy, this trial. Alnylam recently had approval for another drug called vutrisiran, which is a variant in some ways. It's a different cousin, if you will, of patisiran. It uses the same small interfering RNA technology, but it is a subcutaneous administration. It's the second generation subcutaneous drug from Alnylam. And instead of every 3 weeks, it's given every 3 months. And the Helios-A study demonstrated efficacy of this, again, in ATTR polyneuropathy, which led to its approval for ATTR polyneuropathy. So patients who are currently receiving patisiran every 3 weeks could potentially be switched to vutrisiran, excuse me, I think vutrisiran, I'm mispronouncing it, every 3 months, which obviously would be I think an improvement in lifestyle. Now it's being tested in cardiomyopathy in a study called Helios-B, and we'll also eagerly anticipate the results of this study in the next couple of years. Now, patisiran at least requires a pre-medication before the infusion, and that includes dexamethasone, H1 blockers, and typically Tylenol to reduce the likelihood of having a reaction, an immune reaction to the lipid particle that carries the drug. And as I mentioned, all these agents require vitamin A supplementation. Now, using the antisense technology produced by Ionis are inotersen and eplontersen, if I'm pronouncing that correctly, I believe I am. Inotersen is a weekly subcutaneous injection, and it was proven effective in TTR with polyneuropathy using the TTRx study. Now, inotersen actually was shown in that study to actually, in a very small number of people, have a problem with platelet function causing something called thrombocytopenia and kidney function. So it requires regular monitoring of platelet and kidney function upon administration. Now, eplontersen is given every 4 weeks. It uses a different chemistry. It's called a ligand conjugated antisense technology. And so kind of similar to vutrisiran, instead of getting weekly, in this case, it's every 4 weeks administration, and it's being tested in the CardioTransform study. And recently, positive data in the NeuroTransform study, again, I'm sure Dr. Karam will mention this, were reported. Suggesting suggesting an efficacy. So again, we are eagerly anticipating and expecting positive results for the CardioTransform study for eplontersen, as we would expect it would because of the efficacy in neuropathy, as long as the cardiovascular toxicity would be acceptable, and we hope that it will be. And it also requires vitamin A supplementation because of knockdown of TTR production. Now, I think that the ultimate therapy, which is further down the pipeline in development, is the permanent silencing of TTR using CRISPR-Cas9 therapy. And the agent here is called NTLA-2001, made by Intellia Therapeutics, based actually here in the Boston area. Now the Intellia agent uses the CRISPR, which stands for Clustered Regularly Interspaced Short Palindromic Repeats. I cannot say that more than once. When I think CRISPR, I think my refrigerator and what I put lettuce in. But anyway, CRISPR-Cas9 is a bacterial defense mechanism that basically chops up DNA into pieces. And using, again, this is a totally, the science kind of blows me away the way they put this together, but using guiding DNA fragments, they can actually, this therapy is an intravenous formulation, you can see here in this cartoon, that's infused into a patient one time, and it leads to permanent, we believe, permanent silencing by basically cutting the genomic DNA at the point of the TTR gene, thereby ending translation, and you don't make any much TTR anymore. So a single infusion would lead to permanent silencing of TTR. And in the study led by Julian Gilmore, published in the New England Journal of Medicine last year, they reported in the journal 6 patients achieving similar knockdown levels to the regularly administered silencing therapy at 28 days. And so we're going to see follow-up data at longer term from these therapies, but obviously the advantage of this therapy is it's a single one-time administration of a drug, kind of similar to CAR T therapy for different hematologic malignancies that may lead to a solution as opposed to regular administration. Again, we could talk about this in the Q&A. I don't know all that much about this, obviously, just from what I've read and heard, because I'm not involved in these studies, but obviously it's a very exciting technology. Now, let's turn our attention to silencing. And I'm sorry I'm going a little bit long. I'm sorry, stabilizing. I'm going a little bit long, but I hope this is useful for people. So the 2 drugs, and really the only drug that's approved for TTR amyloidosis is tafamidis, also known as, you can see here, Vyndamax or Vyndamax. And as I told you in the earlier part of the presentation, tafamidis plugs into this binding site and stabilizes TTR and keeps it from breaking apart and misfolding. And that was demonstrated in the ATTR ACT trial that was published in the New England Journal I think in 2018, and it was approved in 2019. So we've had this drug for about 3 years. And diflunisal is an alternative in some individuals, and we can talk about this. It's not FDA approved, but at my center and in others, it has a use, and I'll talk about that. Its efficacy was demonstrated at my center by John Burke, published almost 10 years ago in the diflunisal trial. Diflunisal is a non-steroidal approved drug. It's a painkiller like ibuprofen that was approved for arthritis. And we use it at lower doses as a TTR stabilizer. And so, and it is, I believe, quite effective. Now, stabilizers have an advantage over silencers because they're orally administered small molecules. So they're pills that you take every day as opposed to injections, and they bind to TTR and inhibit misfolding. But just like the silencers, they're reversible and they're shorter acting. So that means you have to take the pill every day, or in the case of diflunisal, twice a day to keep up blood levels. And once those blood levels go down, TTR can resume its misfolding. And that can be, and so that's why taking them every day is important. However, because it's TTR amyloidosis is such a slow developing disease, if you miss a couple of doses, it's not going to change really the course of your disease. But if you miss, say, 6 months to a year of doses, that might be different. And pills are easier to take. I mean, we mail them to patients. They don't have to come into infusion center or give themselves shots or have nurses come to their houses. So obviously, at oral, there's a great advantage to oral administration. Tafamidis is a once daily pill, 61 milligrams in the formulation of Vyndamax. Incidentally, that was not the form that was tested in ATTR Act. The form that was tested was called Buchele, which is a 4 times 20 milligram pills. These are big pills. This is much easier to take, and efficacy. Equivalency was demonstrated as prompting the FDA to approve Vyndamax as well without it being actually tested in the clinical trial. Tafamidis has almost no side effects, and there are rare side effects that patients do experience, but by and large, most of the patients I put on it, nearly all of them, don't really have side effects from the drug. And that was borne out in the ATTR Act trial, where there are actually more side effects, equivalent side effects with placebo than there was with actually the drug. And I told you about its efficacy. Now, there are a couple interesting caveats about tafamidis. First of all, the survival benefit was actually seen after 18 months. So yes, the drug makes people live longer, but they have to take it for almost 1.5 years before those curves begin to diverge. And that speaks to the slow progression of ATTR amyloidosis, particularly the ATTR wild type. And people generally don't really feel better. They may feel better because we make other changes in their medications, like we stop their metoprolol or we increase their diuretic, but they don't really generally feel all that much better. They just, if they weren't taking the drug, they feel better than they would have. And so that's why the curves begin to change when you look at quality of life measures, et cetera. But they certainly don't, feel as bad as they would if they didn't take the drug. And as I mentioned, it's the only approved drug in the United States for ATTR cardiomyopathy and the only approved drug for wild-type amyloidosis presently. I mentioned diflunisal. Diflunisal is a non-steroidal anti-inflammatory drug like ibuprofen, given at lower doses. And I mentioned its efficacy in the diflunisal trial. It wasn't tested in cardiomyopathy. It's never been tested in a randomized placebo-controlled clinical trial. So the rigor and the evidence that supports diflunisal is not as good as tafamidis, no question. But retrospective small studies, many of which that have come from our institution, as well as some that have come from others, demonstrate that it can be effective in slowing the progression of disease and improving survival actually fairly dramatically in patients who get it, particularly at an early stage of disease. Now, you have to be careful with diflunisal in patients with moderate to advanced kidney disease. It can potentially facilitate gastrointestinal bleeding, although I will tell you, I really haven't seen that. And the great advantage of diflunisal is that it is cheap and it is reliably inexpensive, although there have been shortages of the drug relatively recently, just like supply chain interruptions for many other things. But it can be used as an alternative if people can't afford tafamidis, as I'll talk about in a few minutes, although we certainly do everything we can to get people drug, tafamidis that is. And it also can be useful for people who have very early disease that don't meet the criteria for tafamidis or silencer. They may have a little bit of neuropathy, or we're not sure, or they have a gene variant, and they have very early changes that don't really kind of, again, meet the qualifying findings to qualify for these drugs. Wrapping up in the next couple of slides, AG10 or acoramidis binds to a different site on TTR and has a higher stabilizing efficacy, so that efficiency, so the drug leads to higher prealbumin levels. And the trial that will demonstrate, we hope, whether it works or not is called ATTRibute. But unfortunately, released a couple of months ago, ATTRibute did not meet its primary endpoint at 6 months. 12 months, which was change in 6-minute walk distance, because the placebo patients did so well. And so we can talk about that potentially later in the Q&A. But the trial is still ongoing, and we will see whether or not acoramidis is effective as the other drugs will. But acoramidis has kind of, in some ways, a disadvantage of being tested in the background of other drug approvals. But theoretically, if it stabilizes TTR more effectively, it might be effective or equi-effective potentially as the other stabilizers. And so the cartoon here basically summarizes the way in which these drugs work. Inotersen and eplontersen work in the nucleus by basically knocking down mRNA before it gets out of the cell nucleus. Patisiran breaks it down in the cytoplasm. And once the protein is secreted, you've got these other agents like tafamidis, diflunisal, and acoramidis that stabilize the drug in circulation. So there are other agents that are in development that I don't want to spend more than 10 seconds talking about, maybe 15. Antibodies to TTR deposits. This is a great idea. Harnessing the immune system to use the body to break down TTR and let the body reabsorb it. They have not proven effective yet, unfortunately. And so, or at least there hasn't been a good balance of efficacy versus toxicity. And tolcapone, which is another agent, I know that was on that in your first slide, that could potentially be effective in CNS amyloidosis, particularly leptomeningeal hereditary variants. These other agents are, I think I would say, almost of historic interest, and we don't typically use them in the management of ATTR amyloidosis anymore. And finally, I want to talk about cost, and I'm sure you'll have questions about this in the Q&A. These are drugs that were approved under orphan drug designation, and they are very, very expensive. As you can see here, the average wholesale price listed in a recent publication just a few months ago for these agents. And many patients, I think, kind of have sticker shock when they see what these drugs could cost. Now, and tafamidis likewise is very highly priced at the initial pricing, $616 per day, right? But nobody, patients, I should say, don't pay this. Most of these drugs have really very, very effective copay assistance programs from the manufacturers. And most patients that I treat do not see copays that obviously are anywhere near what you would expect based upon the pricing of the drug. And part of it has to do with coverage from Medicare Part D if they're over 65 and eligible. Part of that has to do with copay assistance programs from the manufacturers. And part of it has to do with the availability of foundation grants and other sorts of ways in which specialty pharmacies can support copay assistance. But the system is paying for these drugs, and so there is a cost. But I tend to concern myself less with the cost of the system because I'm not a healthcare economist, and more to the cost to the individual patient. And I would say that as we get more approvals, we're hoping that many of these trials that I mentioned to you will be positive. We'll have some competition, and patients will have options, and so that may lead to a downward pressure on pricing. But by and large, I think right now we have a situation where certain drugs are approved for certain indications, and again that leads to differences in access to drug. Different people have different copays depending upon their insurance coverage and where they are and what's available to them. But again, we can talk about that more in the Q&A. So I know I went over. I'm sorry. I hope this was useful to you. It's really an exciting time in ATTR amyloidosis therapeutics because we have so many available therapies and more that we hope will become available in the next couple of years. And I do think the evidence is very strong that these therapies blunt or stop the progression of disease, certainly in hereditary neuropathy. We hope also in cardiomyopathy. Certainly been the data with tafamidis definitely shows significant slowing of disease progression. And so I think it's really, really an exciting time. And when patients come to me, I try to always infuse the visit with optimism that we can definitely bend the course of the patient's disease and hopefully afford them the best possible quality of life. And so with that, I'd like to stop and thank you all for your attention. Again, apologize for going late.
Thank you so much, Dr. Ruberg. That, like like all of our talks, we get educated, but it does tend to generate more questions. And we've got lots of them, but we're going to hold off until Dr. Patel gives us his presentation. And Dr. Patel is on next, and he's going to give a presentation more on the non-ATTR specific therapies treating the symptoms. And I know many of you have sent in emails requesting this, so we really appreciate Dr. Patel giving us time on that. So Dr. Patel, take it away.
Muriel, thank you so much for inviting me. It's always a pleasure to speak at this forum, albeit virtually this time around. Can you see my slides okay?
Yes, absolutely.
Great, thank you. So Dr. Ruberg very eloquently went into the exciting area of ATTR targeted therapies, which is making such a big impact on the outcomes for patients. What I'd like to concentrate on this talk is the management of the complications that ATTR leads to, both predominantly with respect to the heart, but as you can see from this slide, the disease can really affect many other parts of the body. Generally, as Dr. Ruberg mentioned, the infiltration of the protein in the heart leads to thickening and stiffening of the heart, and the predominant outcome of this is that patients develop heart failure. Interestingly enough, there is also an association with the development of aortic stenosis, the narrowing of one of the heart valves, that has been associated with this condition. And I'll talk a little bit about what happens with this as well. Other complications with respect to the heart include the development of an abnormal heart rhythm called atrial fibrillation. And this can worsen symptoms of heart failure, but can also importantly increase the risk of stroke, and its management can be somewhat challenging. The neuropathy, I will leave the aspect of neuropathy management to Dr. Karam, but it can also lead to something called orthostasis, where patients are not able to maintain their blood pressure when they stand up. This is a particular problem in patients with the hereditary form of the disease. And then there are some orthopedic complications, including carpal tunnel syndrome, spinal stenosis, tendon rupture, and the frequent need for joint replacements, all a consequence of ATTR protein interfering with those symptoms. So studies have certainly shown that carpal tunnel syndrome is quite common in patients with ATTR cardiomyopathy, particularly wild type. Up to half the patients with that condition have carpal tunnel syndrome. And while this can be managed surgically, it can also lead to some degree of recurrence. Spinal stenosis is also quite common. It's due to the buildup of the amyloid protein within the spinal canal, and can be seen in up to 45% of patients having surgery for this condition, and can be quite debilitating. I mentioned the orthopedic manifestations. A third of the patients can develop biceps tendon rupture. That can certainly lead to the muscle just popping and weakness. A quarter of the patients in a study looking at rotator cuff repair were noted to have wild-type ATTR deposits, and generally knee and hip replacements are 3 to 5 times more common among patients with ATTR amyloidosis than age and sex-matched controls. And many of these studies actually were spearheaded by Dr. Ruberg and his contribution to this field. Well, what happens when patients develop heart failure? Typically, when patients develop heart failure, when there is a drop in the ejection fraction, which is a common form of heart failure, we treat these patients with a number of drugs called ACE inhibitors, angiotensin receptor blockers, or sacubitril, valsartan, or Entresto, and beta blockers. Well, and when patients develop amyloid heart failure, sometimes physicians may want to try these drugs for treatment, but unfortunately, amyloid patients really do not tolerate these medications very well because the stiff heart does not respond well to these medications. And patients, when they're tried out on these drugs, frequently end up with low blood pressure and worsening symptoms. So you have to be very careful when you're using these drugs in patients with cardiac amyloidosis. The principal manifestation of heart failure is congestion or fluid retention. And this is usually treated with the use of diuretics. But because of the effect of congestion leading to swelling or edema in the bowel, the most commonly used diuretics may not be as effective. And sometimes we need to go to what we call diuretics with increased bioavailability, where they are absorbed more efficiently through the bowel, such as bumetanide and torsemide. There are some data to suggest that patients who have a restrictive cardiomyopathy may benefit from a class of drugs called aldosterone antagonists with respect to decreased hospitalization. And it's reasonable to try these drugs out in the amyloid population. And these include spironolactone and eplerenone. Generally, these are not strong diuretic agents, but they may have some benefit in terms of management of the symptoms, particularly, but they do require some monitoring of kidney function and potassium, which can be elevated. A new class of agents have been really quite exciting in the field of heart failure in general, and particularly in patients with heart failure, and possibly in patients with heart failure with restrictive features. And these drugs, such as Jardiance, Farxiga, and Invokana, may have a potential use here, although they have not been well studied specifically in the amyloid population. With regard to congestion, we do counsel patients on the importance of salt and fluid restriction and weighing daily and adjusting the diuretic so that there's no significant fluid retention. Now, one of the other components one of the other consequences of amyloidosis is that because the protein infiltrates the heart, as you saw in Dr. Ruberg's slide, it can interfere with the electrical system of the heart and lead to slowing down of the heart rhythm, and even what we call heart block, where there's no conduction of the heart, requiring the need for a pacemaker. And typically, patients undergo placement of a pacemaker just under the collarbone with wires that lead into the heart. But more recently, a much smaller device has become available, which measures about an inch, that can be easily placed into the distal portion of the right side of the heart that can perform the same function. And this is much more easily placed. And this is having an increasing use in patients who develop heart block. The use of heart defibrillators, or something we call cardiac resynchronization therapy, where we use the pacing of both the left and right side of the heart. These are common therapies in patients who develop heart failure, where the heart function is decreased. Their role in amyloidosis is really not very well defined, and this is an area of active research. But there may be some patients who may specifically benefit from consideration of these therapies. Now, I earlier mentioned atrial fibrillation as an important feature of cardiac amyloidosis. What is atrial fibrillation? On the left, you can see that in a typical heart, there is the heart has its own pacemaker called the sinus node, and that has its natural tendency to emit an electrical signal, which leads to propagation of the signal to the rest of the heart, and resulting in a typical regular heartbeat. In atrial fibrillation, what happens is that the sinus node ceases to function because there is an irregular impulse that occurs from multiple areas from the upper chambers of the heart. And as a result, the heart rhythm becomes irregular. And the consequences of this is that as patients may develop symptoms such as palpitations from the irregular and often rapid heartbeat, it frequently worsens heart failure symptoms because the heart becomes less efficient, because the upper chambers no longer contract and push blood into the lower chambers of the heart. Patients may also develop dizziness and blackouts because the heart becomes less efficient, or the heart may become very slow. But the most important complication of atrial fibrillation is that because the upper chambers no longer contract, there is an increased risk of blood becoming stagnant in the upper chambers of the heart with the development of clot. And that clot can subsequently be thrown off into the circulation and lead to the development of stroke. And therefore, if patients with cardiac amyloidosis develop atrial fibrillation, it is extremely important that they are considered for therapies with blood thinners to reduce the risk of stroke. Now, management of atrial fibrillation can be quite challenging in amyloid patients because certain drugs such as diltiazem and verapamil are contraindicated. And the reason is that these drugs tend to bind to amyloid fibrils and lead to heart toxicity. So we generally tend to avoid those. Other drugs are available, such as amiodarone and digoxin, that can be used with some degree of caution because they do slow down the heart rhythm. And so you need to monitor for a slowed heart rate, which is something that is that amyloid patients are predisposed to. The same occurs with beta blockers, which can, although control the heart rate, sometimes the heart is actually dependent upon a certain heart rate to continue to beat efficiently. So it can, they're typically used, but they require close monitoring. One aspect of treating the atrial fibrillation is to use something called electrical cardioversion. What we do here is we give the patient an anesthetic and put them to sleep for a short period of time, and then deliver an electrical shock across the heart. And what this does is that it resets the heart with the sinus node, hopefully getting back and leading to a regular heart rhythm. And I'll go into some results with regard to how effective this is in the amyloid patients in the next couple of slides. I mentioned the importance of anticoagulation, and fortunately we have drugs these days which are relatively easy to use, the direct oral anticoagulant agents such as Eliquis and Xarelto, but warfarin may also be used as well. More recently, there is a device that has been developed which can be delivered into the part of the heart where the clots tend to form the most. And on the right, you can see a figure where using a catheter from the groin, an umbrella is delivered to the left side of the heart to occlude the area where the clots form. Now, this is being increasingly used in patients with atrial fibrillation in the general population where this arrhythmia is quite common. However, we really don't have good experience in amyloid patients, and generally amyloid patients do have a higher tendency for clotting in the heart. And so we're not sure how effective this may be in patients with amyloidosis. And this is an area of ongoing and active research. Another increasingly popular treatment for atrial fibrillation in the general population is a procedure of ablation, where again, we put catheters into the heart, and using these catheters, as you can see in the middle figure here, there are a number of burns made within the heart to isolate those circuits and thereby prevent the propagation of those electrical impulses to cause atrial fibrillation. However, again, this is a therapy which can be particularly frustrating in amyloid patients because there is an additional complication in amyloid patients in that the upper chambers of the heart also are infiltrated with amyloid. And so this therapy can also sometimes require multiple treatments or may not be effective. Sometimes patients can have a very rapid heart rate as a result of the atrial fibrillation, which cannot be controlled with the drugs that I mentioned. And one way of dealing with this is to essentially block the conduction between the upper and the lower chambers of the heart, and then subsequently put a pacemaker in, as you can see on the left here. What this does is that the patient remains in atrial fibrillation, but doesn't have the complications of a rapid or irregular heart rate impacting the heart and causing symptoms. But this does mean that the patient subsequently becomes pacemaker dependent. So a number of different treatment options available for atrial fibrillation, but again, this can be somewhat of a challenging area to address. And the other issue is that atrial fibrillation is quite common in ATTR cardiac amyloidosis. As you can see from this study published a couple of years ago, in patients with hereditary ATTR, more than half the patients develop atrial fibrillation, and more than 3/4 of the patients with wild-type ATTR develop atrial fibrillation. And it appears to be more common in patients with more advanced form of the disease. And in terms of management options, you can see that about 1/3 of the patients end up with drug therapy or antiarrhythmic therapy, AAT noted here. About just under half the patients undergo electrical cardioversion, less than 10% undergo ablation, and about 4% undergo AV node ablation with pacemaker implantation. In this particular study, fortunately, there was no suggestion that the development of atrial fibrillation was associated with increased mortality compared to patients who did not have atrial fibrillation. And you can see here that with regard to the effectiveness of electrical cardioversion, patients who have earlier form of the of cardiac amyloidosis tend to have a greater efficacy from cardioversion with maintenance of the regular rhythm at much higher rates at above 90% at 30 days, compared to more advanced disease where at 30 days, the number of patients with maintaining sinus rhythm is significantly lower. So how severe the amyloidosis is how severely the amyloidosis is affecting the heart has an impact on how effective this particular form of therapy is going to be. Now, I mentioned that there has been an association of aortic stenosis in patients with cardiac amyloidosis. In studies, 6% of patients with severe aortic stenosis undergoing surgery for aortic valve replacement were noted to have ATTR deposits. And in patients above 65 who were referred for a newer method of treating this, this condition using catheters, 16% of these patients and 22% of men had evidence of ATTR cardiomyopathy by imaging. So there appears to be an increased association. And what happens in aortic stenosis is that the valve that essentially prevents blood from going back into the heart after the heart has pumped becomes narrowed. As you can see here, and that because of the narrowed valve, the heart, of course, has to work much harder to pump blood out of the heart. What does this lead to? Well, patients typically have much worsening in terms of shortness of breath, something that the amyloid patients, unfortunately, that affects the heart are already predisposed to. Aortic stenosis can lead to the development of chest pain, worsening of the heart failure, patients can actually pass out if not enough blood is able to be pumped out of the heart, and it can also trigger abnormal rhythms, particularly atrial fibrillation. Now, typically, the method for treating aortic stenosis has been to do open heart surgery. And of course, patients with amyloid cardiomyopathy may be at particular increased risk of having open heart surgery. But fortunately, more recently, we have the availability of technologies that are able to replace the valve using catheters. The catheter is deployed through an artery in the groin, and the new valve is actually carried at the tip of this catheter, and it's crimped over a balloon at the tip of this catheter. The catheter is then across the narrowed valve, and then the balloon is inflated to deliver the new valve over the narrowed valve, crushing the old valve across, so that you're left with this newly deployed valve, which has a much greater area than the previous valve, and so blood can flow much more easily across the new valve. And this has really been a game changer in the management of patients with aortic stenosis, particularly if they have other factors which may put them at increased risk of open heart surgery. Now, I'd like to focus a little bit on an area which is increasingly being a therapy that's increasingly being used in the management of patients who may have a more advanced form of the disease that really have not had much benefit from the existing therapies from TTR-directed medications that Dr. Ruberg mentioned. And this is heart transplantation. Now, this is a difficult area because heart transplantation requires that the patient be fairly robust in terms of the rest of the body to be able to undergo the treatment, and then also be able to sustain the use of medications that prevent rejection after transplantation, all of which have their own side effects. And so the patients have to undergo thorough pre-transplant screening. Patients do require predominantly cardiac involvement, mainly because we don't want patients to be transplanted and then subsequently be impaired by progression of their amyloid in other organs, particularly with respect to neuropathy. Now, particularly wild-type ATTR cardiomyopathy is a disease of aging, so many patients may be too old to be considered for heart transplant. But in our program, we've been able to transplant patients generally between the age of 70 and 73, and the oldest patient we've done is actually 78, who's doing very well. So under scrutiny, patients can undergo this treatment with good success, as I'll show you. Now, patients who have advanced kidney disease may be considered for dual organ transplantation, where they have a heart transplant followed by a kidney transplant a few hours later. Patients with advanced neuropathy or autonomic dysfunction, where they can develop blood pressure issues, are excluded because they have a hard time coming off pump after the transplant. And we generally require patients to be able to walk prior to their most recent hospitalization. Patients who have weight loss need a comprehensive evaluation of their gut with endoscopy and biopsy to make sure that it is not due to amyloid that they're having weight loss, because this is something that's not going to get corrected after heart transplantation. And this can be a particular problem in patients with the hereditary form of ATTR. The Heart Transplant Selection Committee determines the final eligibility for this form of therapy in conjunction with amyloid specialists from hematology and cardiology. And you can see that this is experience from our program. We have now done more than 50 amyloid patients over the last 8 years or so. And I'd like to kind of focus in on some aspects of this somewhat complicated table that I apologize for, but you can see that the average age of the wild type patients that underwent transplant is 71. The hereditary patients tend to be younger, 68 or 66. And AL amyloid, which is a distinct condition, can affect patients at a much younger age. And these patients are transplanted consequently generally in their 50s. And in this study, we compared the outcomes to patients who have a similar form of cardiomyopathy we call restrictive cardiomyopathy, not related to amyloidosis. And those patients also tended to be on the younger side. Now, most of the patients awaiting heart transplantation with amyloidosis tend to be very sick, and they're listed what we call status 1 at transplant. That means that these patients are so sick that they're in the hospital, unable to be discharged, and often requiring medications or support to maintain their heart function while they're awaiting heart transplantation. And as you can see here, in terms of ATTR cardiomyopathy, 70 to 80% of the patients we transplant are patients that are in that category of illness. We often use mechanical pumps as a bridge to transplant, but unfortunately, amyloid patients are frequently not candidates for mechanical pumps because the heart chamber is too small to allow a cannula to be placed within the heart that sucks blood out of the heart to allow a pump to function. But in rare cases, we're able to perform what's called a total artificial heart, where we take the entire heart out and put a mechanical pump in as a bridge to transplant. This is a treatment that can be very difficult to do, and so we are very selective with regard to that. How do these patients do? Well, they actually do pretty well. These are 3-year outcomes of almost 50 patients with all forms of amyloid, but as you can see here, 18 patients with wild type TTR and 18 patients with hereditary TTR. Survival is in the 80% range for these patients at 3 years. And in terms of post-transplant complications with regard to rejection or other complications, these patients do comparably well to patients who undergo heart transplantation for other conditions. And when we look at 10-year survival, patients with amyloidosis have a 75% survival after heart transplantation, which is a little bit less than non-amyloid patients, as you can see here in our program at 82%, but nonetheless much better than patients who with advanced heart disease from cardiac amyloidosis if they did not undergo transplantation. So in summary, management of both cardiac and non-cardiac complications of amyloidosis remains an important component of care in addition to ATTR-directed therapies. Management of heart complications can significantly impact symptoms and quality of life, and cardiac transplantation is an option for select patients with disease predominantly restricted to the heart. And I will stop there, and I'm happy to take questions during the Q&A session. Thank you for your attention.
Thank you so much, Dr. Patel. I have a feeling your business is going to start booming even more than it is now that you did that heart transplant presentation. So be prepared for a few phone calls, right? and your presentation combined with Dr. Ruberg's presentation, I think is an ideal primer for anyone who wants education on cardiac amyloidosis. So we can't wait to share those as soon as Bob gets those up on the website and our YouTube channel. So now we have some questions, and before we hear from Dr. Karam, so if we could have our two brilliant cardiologists up on the screen, and we can ask some questions, okay? So here is the question. Well, you actually answered some of these questions so beautifully in your presentation, but we'll go for it anyway. Is there any type of heart ablation for the lower ventricles that have become stiff and thick? And Dr. Patel, you mentioned ablation, so
Yeah, so the ablation procedure I mentioned was to treat a rhythm. I think what is being referred to here is ablative therapy to thin the heart down, if I'm correct. There can be a rhythm problem that can affect the lower chambers of the heart, something we call ventricular tachycardia, and that can sometimes be seen in patients with cardiac amyloidosis. And if they have significant symptoms from that, certainly ablation of that arrhythmia is an option. However, the ablative therapy to thin the heart muscle down, which is something that has been done in patients with another condition called hypertrophic cardiomyopathy, this is something that can't be done in amyloid patients simply because the thickening of the heart is very diffuse and affects all aspects of the heart.
thank you, Dr. Ruberg. I see you nodding. Do you have anything to add to that?
No, that was wonderfully eloquently said. I completely agree. I guess one thing I would add is that the potential for antibody therapies is that theoretically, one could if they worked, one could resorb the amyloid and thereby thin the heart. And that's, I think, what the promise of antibody therapy holds, is that you're basically removing the fibrils in between the cells come closer together, they remodel, the heart gets thinner, and the diastolic relaxation, stretchiness properties of the heart are restored. That promise has not yet translated into reality, but we await the results of, there's one trial right now in AL amyloidosis using antibodies, and there will likely be future trials in ATTR amyloidosis.
Thank you.
Yeah, it's actually, we're about to start a clinical trial. I think the first patient is going to be enrolled August 4th, looking at this specific therapy in ATTR cardiomyopathy. So it's going to involve about 100 patients enrolled across centers across the world. So we eagerly await the outcomes of that particular study.
Super. What drug would that be for, Dr. Patel?
That's the PRX001, which is now got another number to it, which I can never remember because the drug has been drug is now being purchased by Novo Nordisk.
Right. Is that X4 rather than X1? I thought it was.
Yeah. Yeah, I can't remember them.
Okay, we did invite Novo Nordisk to be here today. I think we had a translation problem or something, but they will be at our next one for sure. Okay. Here's another one talking about heart transplants. And I think you did this, who are the ideal candidates? I think you went through that really beautifully. How often are they done? You answered that. How successful are they? You answered that. So this one goes on the floor. Okay, next. I've been on Vyndamax for 6 months. When will I be tested to see if it has slowed or stopped the progression of my disease? What tests will be used to monitor my progress? We'll go with Dr. Ruberg first on that.
Yeah. Such a good question. I mean, I get that question asked all the time, and it's an important question that we doctors ask, and patients certainly ask too. So how do I know whether the drug is working? You know, how do I know? And in the case of Vyndamax or tafamidis, it doesn't in some ways matter as much because we don't really have alternative therapies now, but we will in a couple of years. So it will be important for us to know whether a patient is responding, if you will, to a drug. And so I can tell you that there are no consensus recommendations on how to follow, although I should say that's not true. The European guidelines did elaborate certain testing that they recommend for following response, testing to perform, but the specific thresholds that we might use to say, well, this increased by this or this decreased by that, those have not been established. But I can tell you that it's going to be some combination of blood testing and probably imaging. And that's kind of the way we do it in AL amyloidosis as well. But in AL, it's easier because we know we have a protein, the light chain, that we can follow. In ATTR amyloidosis, we can follow TTR, and we believe that in certainly the case of, we know that in silencers, the TTR production goes down very, very low. That indicates the drug is working in terms of knocking down TTR. Is it necessarily improving someone's outcome? That's time will tell that. And in the case of tafamidis and stabilizers, the TTR level actually paradoxically increases, and that we think indicates stabilization of the molecule. But it'll be a combination of blood testing. So prealbumin will probably be followed. Heart-specific markers like BNP, troponin, NT-proBNP will be followed. And imaging of some component will be followed. That imaging could include echocardiography. I really didn't talk at all about that in my presentation, but there are certain variables that we may choose to follow that have been, again, shown in AL amyloidosis to be useful, and potentially advanced imaging like cardiac MRI or nuclear imaging with the radiotracers, pyrophosphate, HMDP, HDP, or DPD. So it will probably be some combination of that. I can't tell you what those specific thresholds are like I can in AL. In AL, I could say, well, if your NT-proBNP drops by more than 30%, then you're a cardiac responder. We don't have that evidence base yet in ATTR, and that's something we're working towards.
Thank you. And Dr. Patel, is there anything you'd like to add?
No, I think Dr. Ruberg eloquently kind of mentioned the challenges we have in monitoring these patients for response. And one of the things I routinely do is actually check the prealbumin level before I start tafamidis, and then repeat it after on treatment and see what the change is with that, which suggests that there is some efficacy of the drug in terms of stabilizing the protein. In terms of what's happening to the heart, that's a challenging area because we just don't have the technology yet to really look at that very effectively in individual patients. In clinical trials, when they look at large number of patients, you can see some changes that on average that are favorable, but for individual patients, it's much more challenging.
Thank you. Okay, well, here's another kind of follow-up. This person wants to know, is there a chart that indicates range of cardiac biomarkers to help patients figure out the meaning of levels? So this is a little bit different. I know we have a chart for our AL patients so they can follow, what's normal in free light chains and cardiac biomarkers and everything. But is there a chart for ATTR, or could one be developed?
Well, there are staging systems for ATTR that kind of mirror the staging systems for light chain. Or maybe that's what the question is asking. And in ATTR amyloidosis, for wild type, and V122I variant ATTR, there are staging systems. The two staging systems that have been developed and reported are, one is the National Amyloidosis Center in London staging system for ATTR wild type and ATTR V122I that uses a combination of kidney function, something called the eGFR, or estimated glomerular filtration rate, and NT-proBNP. And the cutoffs that dictate the change in stage there are 3,000 for NT-proBNP and 45 for eGFR using a particular formula. There's different formulas for calculating eGFR, so it gets a little complicated. And for the wild type staging, that was also reported by the Mayo Clinic, and in that staging system, NT-proBNP and troponin T was utilized. And that also can be a little confusing because there are different troponin generation assays, and one can't really, it's difficult to kind of look at numbers unless you know specifically the type of assay you're using. So, but generally speaking, the concept is that higher markers indicate a kind of a disease progression, and lower markers are better. But those thresholds can be challenging to generalize across these different assay types.
Okay, and you already answered this question, which was, what do the number, how do we know when the Vyndamax is working? And you said you really couldn't tell by looking at troponin and NT-proBNP like you can with the AL patients, whether the heart is improving, but.
Well, may I interrupt? Sorry.
Sure.
I mean, we look for lack of progression, and generally, and we know that stabilizers lead to stabilization, not only of TTR, but also of these markers. So generally, if a patient is responding to tafamidis, you will see the prealbumin go up, usually 5 milligrams per deciliter or more. And this was actually reported by the Brigham group, Sarah Cuddy, Rodney Falk et al., Sharmila Darbala in a paper earlier this year in one of the JACC journals. And so we know, and we've seen this obviously as well, that the prealbumin rises. Not obviously, we've seen this, and the TTR constant. I'm sorry, the biomarkers tend not to get worse. In a patient who's not responding, we don't exactly know what we will see, but you would expect that number will tend to increase, those numbers, and the prealbumin level will either go down or certainly not go up. And that in combination with worsening heart function by echo and worsening clinical stage, how people feel, how far they can walk, maybe their responses to questionnaires can all indicate whether a drug is working or not.
Dr. Patel, you answered you discussed these drugs in your presentation. This person, they wrote amlodipine, but I don't know if that's really amiodarone or if there is a drug amlodipine. But this person's asking amlodipine and losartan issues with what? Are there any issues with wild type or any issues combining with Vyndamax?
Yes, amlodipine is a blood pressure drug. It's a calcium channel blocker. It is not the same type of calcium channel blocker such as diltiazem and verapamil, which can be problematic using in amyloid patients. So in patients who have high blood pressure, it can be used. It can sometimes exacerbate swelling or edema as a side effect. Losartan is an angiotensin receptor blocker, one of the drugs that I said can lead to some problems in patients with heart failure due to amyloidosis. However, many patients who, particularly with early form of the disease that need treatment for high blood pressure, many of my patients are able to tolerate drugs in this class, losartan. But they require continued monitoring and close monitoring, particularly with respect to the blood pressure. So I always encourage patients to continue to monitor their blood pressure at home on these therapies because they may require dosage adjustment with time.
We're going to do one more question, and then we'll put the rest off till after Dr. Karam's presentation, because I know everyone's eager to hear it. But I just want to do one more question here. Would a viral or bacterial infection cause a spike in either BNP or troponin?
I guess I can start and we can both answer that one. So generally, if it depends on the virus, I guess is the answer to that question. I mean, an upper respiratory tract virus that causes a cold will not likely necessarily be expected to have any effect on worsening heart failure or affect the heart specifically. But a more virus that causes more systemic illness, fevers, an immune reaction, or infects the heart itself can certainly cause those numbers to go up. And so, like I said, I think it depends on the virus. And if the question is about the COVID virus, that's even a little bit more complicated. The systemic inflammatory response that results from COVID can definitely injure the heart. We know that. And so, or influenza, another systemic illness. So I think it depends on the type of virus that we're looking at. I'm sure Dr. Patel has thoughts on this too.
Yeah, no, I have little to add here. If the virus causes systemic illness, it can exacerbate heart failure, particularly if you have, for example, atrial fibrillation, or you can go into atrial fibrillation, and as a result of that, your pro-BNP values will shoot up, and you'll certainly get worsening of heart failure symptoms. And troponins can sometimes be affected depending upon the type of virus, particularly with COVID, as Dr. Ruberg mentioned.
Okay, thank you so much. We'll continue with these questions in a bit, but now we're going to hear our neuropathy presentation from Dr. Chafic Karam from the University of Pennsylvania. Dr. Karam, welcome.
Thank you, Muriel. So just to verify, you can see my slides, correct?
Correct.
Okay, so let me put play here. I'm going to be discussing neuropathy and amyloid, the symptoms and management. When we talk about neuropathy, we are talking about the yellow lines that you see here. So usually the central nervous system consists of the brain and the spinal cord. And most of the time, these are spared in amyloidosis, where in hereditary amyloidosis, although certain mutation can affect the brain and spinal cord, but most of the time they are spared. And when we talk about the peripheral nervous system, we're talking about once the nerve exits the spine. So these nerves can go to the arms, to the legs, or to the heart, blood vessels, and GI tract. That's the autonomic nervous system. How does the nerve work? They really work like electrical wire and receptors. And what they do is they feel the sensation. They can either tell where your joint is in space. For example, if you close your eyes, you don't fall, you know where your hands and when your feet are. They can tell if you're touching something hot or cold. For example, in this picture here, you have a person trying to feel the temperature. There's a signal that goes through the nerve to the brain, telling the person if this is water is hot and cold. And then you get another signal from the brain that goes down through the nerve to activate the muscle and tell whether you want to increase the warm water or the cold water. The nerves also go to the heart so they can feel how the pressure is changing. And that is why it's important, because we live on Earth, there's gravity. When you stand up, gravity is going to pull down the blood. But if you have receptors that are working, there's a signal that goes through these receptors, through the autonomic nervous system, to the spinal cord, and to the base of the brain, and says, hey, there's a change in position here. Let's ask the heart to beat faster and stronger, increase the blood volume by constricting the blood vessel. And this way, the person doesn't faint when they stand up. And when we talk about peripheral neuropathy, and that's something that I realized it's a little bit confusing, but when neurologists talk about peripheral neuropathy, they mean the person in picture A. So the hand, usually the feet are affected first, and then as the neuropathy gets worse, it spreads upward, and then the hands get affected as well. It's called stock and glove kind of pattern. This is what they typically mean by peripheral neuropathy. However, you can also have pinched nerve in your wrist, like carpal tunnel syndrome, and your hand will give you signs of neuropathy. You have numbness, tingling, burning, pain, weakness in the hand, for example. It can be in a pinched nerve in the back, causing symptoms in the back, or it can be in the nerve going to the heart and to the guts. All of these are types of neuropathy, but it's important when we talk about peripheral neuropathy to just focus on the person in number A, just for the sake of discussing today and in general when you're talking to your doctor. So what are the symptoms of neuropathy? I talked about a few of them, but as I mentioned before, you have the sensation and you have the motor part. Motor part meaning you want to move your hand or you want to move your feet, you want to walk, stand on your tippy toes, etc. And most of the time, the sensation gets affected first, and then as the neuropathy gets worse, the motor and the muscle gets affected as well. What are the symptoms of neuropathy? Dead asleep feeling, which is commonly referred as numbness, although some people mean, when they say numbness, they may mean weakness or something else. But the dead asleep feeling, it's like when you go to the dentist and they inject Novocaine. That's the type of feeling that people get. They can also have a burning sensation or a tingling sensation, or like a pressure sensation, like just wearing compression stockings, or their feet may be wet, or they're wearing socks and they look at their feet and there's nothing covering their feet. They can have hypersensitivity. They cannot feel sometimes the hot or cold. They can burn themselves if they're cooking. And of course, if there's no signal of where the joint is in space, if you're not looking, or if you close your eyes, you can have balance issue. And unfortunately, that can lead to falls and more problem. In the motor symptoms, it's more about the weakness. Imagine trying to zip or close buttons or manipulate small coins, for example. Think about trying to walk on your tiptoes or heels, etc. And all of these can be affected. Now, when we talk about treatment for neuropathy, there's two parts of the treatment. You're treating the symptoms, which is, for example, the pain, the numbness, the tingling, the burning sensation, etc. And there's treatment of what is actually causing the neuropathy. So a lot of time we want to relieve the symptoms that the patient is suffering from, but we also, if we're able to find why they have the neuropathy, we want to try to address it so there's no ongoing insult on the nerve and nerve damage. And we're talking today about hereditary amyloid transthyretin. So we want to try to reduce the amyloid deposition in the nerve and of course other organs, but you want to try to reduce that misfolding of the TTR protein and try to prevent it from depositing in the nerve, because when it does, it is toxic to the nerve and it causes nerve damage and the symptoms of neuropathy. Muriel today asked me to focus on management of the symptoms, but at the end of the talk, I'll talk a little bit about what currently we have for the hATTR neuropathy disease. So what about pain management? Pain is common in people with neuropathy. Not everybody has it. Some people have a little bit of pain. Sometimes it's mainly the numbness and the imbalance and the weakness rather than pain. But if people have the tingling, burning, electric shocks sensation, and this is affecting their life and their quality of life, we would like to try to relieve that symptom. What I would like to point out is that a lot of time when I'm talking with the patient, I'm going to tell them, listen, the medication that I'm going to give you, any drug I'm going to give you will have side effects, unfortunately. So I want you to tell me how bad the pain is. And when you're dealing with the side effects, would you rather have the side effects of these drugs or just deal with the pain? And that's an important thing, because it's very important to understand that these drugs are not fixing your nerve. They're not making the nerve grow back. They're just masking the pain. It's like somebody has pneumonia, they have fever. You give them Tylenol, it reduces the fever, but you're not really treating the underlying infection. You really have to give them antibiotics to cure them. So this is kind of similar thing. And then the other issue that I have with pain and neuropathy is none of the drugs that actually we use for pain and neuropathy were developed for pain and neuropathy. They are borrowed from other disorders. For example, some of the most common drugs we use are antidepressive agents. And I tell the patient, listen, the pharmacist was going to tell you this is an antidepressant drug, or you may Google it, but I am giving it for the pain. Now, if somebody has depression and this helps with the depression, that's great. But this is the reason we give these medication, because we realize that not only they work on depression, they can work on the pain. Duloxetine or Cymbalta is something that I use frequently because it doesn't make people very sleepy, and it doesn't have a lot of side effects on the autonomic nervous system. Same thing for venlafaxine. The other drug, tricyclic, amitriptyline, nortriptyline, I use them if there's not a lot of autonomic nervous system involvement, because they can make the dysautonomia worse. So they can, if somebody has constipation, they'll make it worse. If they have orthostatic hypotension, they can make it worse. But they work really well on pain. They also make people sleepy. So a lot of the time, the neuropathy is worse at night because you have, you're not thinking about anything else and you're not active. And sometimes this is a great way to manage the symptoms of neuropathy is by giving nortriptyline or amitriptyline, and it makes people sleepy. It will also help with the pain. But again, we have to be careful if there's significant dysautonomia, which is common in people with amyloidosis. You're going to have to watch out for these drugs. Other drugs that we commonly use are the anti-epileptic, and the two that we use the most frequently are going to be gabapentin, pregabalin. Again, they have side effects. They can cause swelling. They can cause drowsiness, sleepiness, fatigue, but they also don't interact with other medication a lot. So that's why I do prefer them, especially in people who are taking multiple other drugs. These drugs typically don't interact and cause toxicity. Something that we offer for people who don't want to take pills, they want to try something topical, especially if it's limited, for example, at the toes or at the feet. You can try a lidocaine ointment. It has to be like about 4 to 5%. You cannot just take the over-the-counter, which is about 0.5%. It's not going to help much. And the issue with it, it's a little bit messy. You can get the patch, but it's not going to cover the whole foot. And you have to apply it at least twice a day, sometimes more. But some people can get away with just the topical ointment. Another thing is that a lot of time we use combinations. So if you're on anti-epileptic and it's helping a little bit, adding an antidepressive agent may be even better. We know that exercise is very helpful for the nerve, and a healthy diet can also help with the pain. So we do recommend that people do that. Some people try acupuncture. It can help, but it doesn't, it doesn't necessarily hurt. Well, it does hurt a little bit when you're doing it, but you know what I mean. Something when pain is really refractory, you may want to consider a spinal cord stimulator. That is an invasive procedure. It is expensive. But the good thing about it, you do a trial first before you insert it. And if it helped, then that's great. Of course, opiates are very effective for drugs. The problem that I have with opiates is that there's people get used to them. So you have to increase the dose. So they're really good for short-term pain, but for long-term pain, you're just going to keep increasing the dose, and then it's going to cause a lot of problem. It can also cause people to overdose and die, unfortunately. I would like to just mention carpal tunnel syndrome. This is not this is not what we mean when we tell people you have peripheral neuropathy. It's not the carpal tunnel syndrome, although if you think about it, it is a nerve. It's a peripheral nerve. So why it is, don't ask me. When we talk about peripheral neuropathy, we're not mentioning carpal tunnel syndrome, which causes a little bit of confusion because the drugs, the silencers that are very effective for ATTR are approved for peripheral neuropathy, but they're not really approved for just the carpal tunnel syndrome. But what happened with carpal tunnel syndrome, which is very common in people with amyloidosis, it can happen many years before they even have the diagnosis of amyloidosis. And what happened, you have the amyloid deposition in the transverse carpal ligament, and that will press on the nerve that is going to your index, thumb, and middle finger, and it can cause a pain, discomfort, and it's a treatable condition by doing a small surgery in the wrist and releasing the nerve. Let's talk now about dysautonomia. So the autonomic nervous system is the peripheral nervous system that is taking care of things that are automatic. You don't think about regulating your heart rate. You don't think about moving the food in your GI tract, and so forth. One of the very common signs of dysautonomia is erectile dysfunction. And what I've noticed is that in men, it happens frequently many years before the onset of the disease or before the diagnosis of hATTR neuropathy. Another common problem is an alternation of constipation and diarrhea and incontinence with soiling, which can be really uncomfortable and can prevent people from leaving their house because sometimes it's really constant. Early satiety, meaning you eat just a couple of bites and you feel full. Sometimes you regurgitate undigested food, you get nausea. OH, which is orthostatic hypotension, meaning when you are sitting or laying down, you stand up, your blood pressure drop, you feel lightheaded, you have to hold yourself, you may fall. Sometimes if it's severe enough, you may lose consciousness and hurt yourself. So that needs to be prevented and treated as well. And then another sign of dysautonomia is heat intolerance, because you're not sweating very well or you're not sweating uniformly in your body. So getting out in the heat is going to make you feel very sick. So let's talk a little bit about the management of GI issues. And I usually try to manage them myself, but in case they get a little bit refractory, I do send them to the GI doctor. So diarrhea, loperamide, tincture of opium is really probably the most effective to control these symptoms. For the constipation, senna, docosate, metamycin, there's many different other. For gastroparesis, meaning when you eat, the food just stays in your stomach, it doesn't move down to your intestines. You can use metoclopramide, which also works for nausea actually, or erythromycin. Nausea, vomiting, as I mentioned, metoclopramide or Reglan on the Satron or Zofran. And then we've seen in people who have advanced disease and are cachectic, there's a lot of issues having good appetite, but it's important to really eat well. So we try to give them appetite stimulant to hopefully try to make them eat. Unfortunately, it doesn't always work, and cachexia can be really a bad thing and refractory. How about the management of orthostatic hypertension? This is a little bit challenging, and I think the most important is to educate first the patient about this disorder. So the issue is that usually you've lived all your life not thinking about this problem, right? You just stand up, you're fine, you sit down, the blood pressure is regulating itself. You don't have to worry about this. But if the nerve going to your blood vessel, to the baroreceptors, are not working very well, unfortunately, we are dealing with orthostatic hypertension, and you have to think about it and try to manage it accordingly. So some things that are mechanical to increase the blood flow back to the heart is by putting pressure on the leg or on the abdomen, and that way the blood will go back to your heart and you won't have orthostatic hypertension. Another thing that you can do is at night you raise a little bit the head of the bed. There's wedge pillows that you can buy, and that can also help with this issue. The problem that we have is a lot of people have heart issues, but if they don't, obviously taking a lot of salt and water, increasing the blood volume will be very helpful in avoiding the orthostatic hypertension. Obviously, if you have heart failure, you cannot do that. So you have to take maybe pills. And the four options that we have are going to be midodrine, fludrocortisone, droxidopa, pyridostigmine. Fludrocortisone may give you similar issues with the heart. If you have heart issues, it's because it retains salt and water, and you may want to avoid that. But midodrine, what it does, it constricts the blood vessel. So when you constrict the blood vessel, you have that blood going fast to the heart, and you will avoid orthostatic hypertension. What is the issue with that is that it's not smart. You're raising your blood pressure continuously, meaning if you sit down or you lay down, your blood pressure is going to go through the roof. And that becomes an issue because you may go to the doctor and they may take your blood pressure and it's elevated, and then they'll tell you, oh, you need more antihypertensive, but then you keep fainting. So that is something to think about, and we call that supine hypertension. So because of that, you have to keep a blood pressure log. You have to take your blood pressure sitting or laying down, and then after a minute when you stand, you have to keep an eye on it. If you think you're going to be active a lot during the day, you're going to be walking a lot, then you need to take the midodrine. But if you feel that you're at night, you're watching TV, there's no point of taking the midodrine then. So we tell people to take the midodrine in the morning, at noon, late, early afternoon, but don't take it late afternoon or in the evening, because you don't want the blood pressure to be elevated when you're sitting or when you're going to bed, because that's going to cause a stroke. So hypertension is one of the main causes of stroke. So we want to be careful about that. The effect of midodrine doesn't last very long. So it lasts about 4 hours maybe. So if you, for example, know you're going to go to bed at 10, then probably the last time you want to take it is, around 5 or 6. Droxidopa is another medication that is recently approved. Well, no, not very recently. The issue with it, it's a little bit expensive. So when we prescribe it, sometimes we have to go through insurance issues as well. Pyridostigmine or mestinon is a drug that we use for myasthenia gravis, which is a completely different condition, but we know that it helps a little bit with mild orthostatic hypertension. We know it helps a little bit with the gut movement. So if somebody has a little bit of constipation, a little bit of orthostatic hypertension, we may give them pyridostigmine. How about erectile dysfunction? This is a very common problem. This is in a population of people who don't have amyloid. So even if you don't have amyloid and you're a man, the risk of erectile dysfunction is high. So if you're 40, it could be up to 40%. Now, most of these are mild or moderate. But as men get older, this becomes a more prevalent issue. And not only that, when you have amyloid, the nerve going to the penis are not going to be working very well. So you're going to have even more risk of erectile dysfunction. So a lot of time people ask, how do we manage erectile dysfunction? So there are several options. The issue is is that they may, the pills that work very well may cause side effects, but also may not even work very well for people with amyloidosis, unfortunately. So we have to try different pills. And a lot of time we have to combine with other methods to maintain erection. So there are vacuum devices, there are intra-urethral alprostradil, which is kind of a cream that you put in the urethra and you massage the penis, and that can work. And then sometimes if it's bad enough, you may do injections in the penis, and that could work as well. And then if everything fails, you try a combination of these. And if this is still not helpful, there's something called penile prosthesis surgery, where you put a kind of pump in the penis, and that can help with the symptoms as well. Obviously, for the ejaculation, we don't really have very good treatment. You want to make sure that the patient doesn't have hypogonadism, meaning that the testosterone is low, because then you need to give them testosterone supplements. So there's a few things. I usually send the patient to the urologist to kind of manage these symptoms because they have much more experience than me in that. Finally, there's a thing that we're just starting to pay a little bit more attention to. I honestly don't really know if it's more common in the general if it's as common in the general population, or is it more common in people with amyloid? Because you have amyloid deposition, for example, in the the throat, and that can close a little bit the windpipe, or because you also have heart disease in people with amyloidosis, we know that can cause more frequent sleep apnea. But I think it's good to think about this and maybe study it a little bit more, ask the patients if they have it, because it is kind of a treatable problem. But if it's not treated, it can increase the risk of heart disease, of stroke. People with amyloid already have a lot of fatigue and feeling tired. So if they have sleep apnea, they're going to feel even more tired. They have low energy, poor focus. They can wake up with a headache. And usually what brings the patient is really not just the patient, it's more the bed partner that report that, oh, I feel that they stop breathing during their sleep, and then they start breathing again, they gasp for air, etc. So very important to, if your doctor doesn't ask you about this, and it's not their fault because sometimes they forget, or it's not something that we know about amyloid, but it's something to bring up, especially if you have low energy, or if your bed partner reports that you have a lot of issues snoring, etc. Although please understand that just if you snore, it could be just normal. It doesn't mean that you really have sleep apnea. So there is testing by a sleep doctor that needs to be done to prove that that's what you have. And there are several different treatments for this condition that can help and make people quality of life extremely better after treating it. So if you remember in the beginning, we said there's two things we need to treat in people with neuropathy. We need to treat the symptoms, which are either the pain, the dysautonomia, etc. And we have to treat the cause of the disease. And we've already addressed the different treatment for hATTR earlier today. Currently, the we have now three treatment for hereditary ATTR neuropathy. And that's how, we all know, everybody who's here know that this is one single disease. But unfortunately, the way science work and the FDA works, etc. If you have heart disease, you're going to take the tafamidis. If you have neuropathy, then you're going to be able to take the silencer. And the two silencer or three silencer now that we have are going to be either the patisiran, which is Onpattro, vutrisiran, which was just recently approved, and the inotersen, which is Tegsedi. And these are going to tell the liver to stop making the TTR protein, which is the culprit here. And when you reduce the production of the TTR protein, then you have less amyloid deposition. And when you have less amyloid deposition, the disease usually can either slow down, sometimes halt, and sometimes even reverse, depending on different factors. Okay, stabilizer, off-label diflunisal, you can still use it in neuropathy, and I still use it, and I sometimes use it in combination with the patisiran, for example. Same thing, tafamidis is a stabilizer. You can use that as well if you have heart disease. We don't really know if the combination therapy is superior to one drug alone, but this is an area of research and interest. Tolcapone is probably something that hopefully will be studied at some point soon, because I think it has a very important role, because the drugs that we currently have don't penetrate the brain or the eye. And we know from experience with liver transplant, when you stop the amyloid in the nerve and in the brain and in the heart, people live for very long, you know. But the problem is that after 10 or 20 years, they start having brain issue. And we currently don't really have any treatment, but tolcapone is a promising drug for that. Then finally, if you have the amyloid that's already in the organ, if you had the amyloid already in the nerve, already in the heart, how do we get rid of that? And there's a few theories that we think, we think that if you're able to control the disease, the body will heal itself and you're gonna recover some. Unfortunately, if the neuropathy, for example, is pretty severe, if you have a lot of loss of nerve and axons, then it may not grow back, unfortunately. But we hope that we're now better at diagnosing people early and starting treatment early, and this way we can prevent the irreversible nerve damage. The other thing that is interesting is removing completely the amyloid by asking your immune system to remove them. And basically what you do, you tag these amyloid deposition with antibody, and the macrophages, which basically are what clean your body from infections, are going to try to remove the amyloid and hopefully degrade it. This is still an area of research. The Protina study was a phase 1 in ATTR neuropathy. We cannot really comment a lot on the data that came out of it, but it's definitely promising, and it should be, in my opinion, investigated in type 2 in a phase 2 study. So this is all I have for today, and I'm happy to answer any questions. Thank you very much. Thank you, Muriel, for having me.
Thank you. Thank you so much, Dr. Karam. That was really good. And you covered a lot of things that people have questions on. So if I can have Dr. Ruberg and Dr. Patel and Dr. Karam, and we'll address some questions. We're going to kind of rework our agenda a little bit. We're going to, after we do this Q&A, and we're going to do a 5-minute break instead of a 10-minute break. Okay, and then we're going to hear from Intellia, Michael Maitland. I know people are really eager to hear about CRISPR, so we'll hear about that. And Paula will be moved to the end. Paula's used to being moved to the end. Paula's used to us going over, so don't feel bad about that. Okay, so Paula will be talking about financial issues and other things at the end of this. Okay, so we're just a little adjusting here. Okay, so I don't know who this would fall into, but I'll address you, Dr. Karam, and then we can move down. Can deep unresolvable itching in the front of shoulders be associated with ATTR?
Interesting. So itching is actually a type of pain. I don't know if you guys know that, but some people with neuropathy, the first symptoms they have is itching. Now, the shoulder itself is a bizarre place for neuropathy, but I've seen a lot of bizarre things with amyloid to not say it's bizarre anymore. So it is definitely unusual. I've never heard it before. And again, the neuropathy in amyloid is usually in the feet and the hands, and it can present with itchiness. Actually, one of the first patients that I saw with AL amyloid many years ago, his symptoms was itchiness in the feet. He just, and then when we tested it, he had clear neuropathy, but it wasn't the typical burning sensation, etc. It was more of an itching sensation. So it could be, I'm not sure, it's a weird location, but I think it could be investigated further for sure.
Thank you. Okay, if anyone has anything to pop in on that, feel free. Otherwise, we'll go on to the next one. Okay, this is really an interesting question. This patient had a heart transplant, and 12 months later, they found amyloid in his back after spine surgery. Now, he was told that he would not be approved for any amyloid treatment because there's no amyloid in his new heart yet. So he's concerned. He said he's considering hip replacement, but he's concerned about jeopardizing the soft tissue supporting that hip. But he has a lot of pain in his tissues and joints. So I guess the question is, what can be done for this patient? Just because he doesn't have amyloid in his new heart, would that be a criteria not to give him treatment? Dr. Patel, will go with you first.
Yes, I do have it's a great question. I do have a handful of patients after transplant who are on treatment because they have evidence of amyloid elsewhere. And actually, I've not had any issues with the treatment getting paid for based on the fact that they do have a history of cardiac amyloidosis. So insurance companies don't often kind of go into details as to whether the heart's been replaced or not. And so it is something that can be treated. Of course, I have patients with hereditary ATTR amyloidosis who've undergone heart transplantation, subsequently developed some neuropathy or had pre-existing neuropathy, who need continued treatment for their polyneuropathy with a silencing agents, and those patients will continue with a silencing agent. Now, the use of diflunisal, as Dr. Ruberg mentioned, can be a little tricky in heart transplant patients because it's a non-steroidal anti-inflammatory drug, and it can lead to some kidney issues in heart transplant patients, and patients with heart transplants end up on immunosuppressive drugs that can affect the kidneys as well. So it can be used if the kidney function is normal, but it requires very close monitoring to ensure that the kidneys remain okay on continued therapy.
Okay, thank you. And here's a question, and we see this more and more now with people with wild type talking about neuropathy, and that's usually not discussed very often. But this person says, my husband is 83, was diagnosed with wild type in 2021 of the bladder and heart. The cardiologist believes he's now developing neuropathy of his feet. He's been seeing a neurologist for at least 8 years, but for carotid artery, but the neurologist knows nothing about amyloidosis. My husband started Vyndamax in March 2022. So is there really no other treatment that we know of for him? Would the treatment of peripheral neuropathy of someone with amyloidosis be different from someone who did not have amyloidosis? So we know that the drugs for, the Onpattro drugs and Tegsedi drugs are approved for hereditary with polyneuropathy. But what about the wild type? Are we seeing neuropathy with wild type? And if we are, what can we do for them? So let's start with Dr. Karam, and then we'll move to our cardiologist.
Yeah, that's a great question that I personally struggled with it myself, and I'll tell you why. After the age of 70, about 5 to 10% of the population have neuropathy, even if they don't have amyloid. And then after the age of 80, it goes up to maybe 20%, even if they don't have amyloid. The other thing is a lot of time the pain could be coming from the back. So we know with wild type amyloid, there's a lot of spinal stenosis, and the nerve doesn't care if it's interrupted in the back or in the feet or in the knees. It's gonna give you the kind of similar symptoms of pain, numbness, and tingling. And then finally, the testing that we have for neuropathy are not very good after the age of about 70 to 75. The testing, a lot of things can just look, you stimulate the nerve, you don't get a response, but you say, oh, well, this is common in people who don't have neuropathy, and we attribute it to age. So these are some of the challenges of diagnosing neuropathy and amyloidosis, especially the wild type. So the question first, do they have really neuropathy? Is it coming from the back? Is it coming from the feet? And is it really caused by amyloidosis? Could it be caused by diabetes, by vitamin deficiency, and so forth? So things need to be investigated a little bit more. And then finally, let's assume you say this is amyloid. That's why the patient has neuropathy. Tafamidis is a treatment for neuropathy as well. It's just not approved in the US. So, I would like to comfort the patient that's saying that you are being treated for the amyloid in your feet. But it just because in the US it's not approved, it doesn't mean that it doesn't work on neuropathy. Now it's interesting and I think, as the cardiologists were saying, in a couple of months, maybe in a month actually, we will know if APOLLO-B is a positive study. And then maybe that could be another thing to offer the patient. So, and the symptoms are also treatable. So if the nerve pain is very bothersome, as I showed before, we have several treatments that we can use for the neuropathy as well. But the tafamidis should work on the neuropathy, and then hopefully we'll have additional options in the future.
Thank you. Dr. Patel, Dr. Ruberg, is there anything you wanted to add to that?
Yeah, I would just, so Dr. Karam made the point about tafamidis being approved, not in the United States, but elsewhere in the world for neuropathy. The dose was 20 milligrams and we're giving 61 milligrams. So theoretically, the dose we give for cardiomyopathy is higher, So, so if there is efficacy there, it should be, and it's amyloid, it should be theoretically effective. I was going to make a point about the previous case, which kind of combines this one, and that is that amyloidosis is a systemic disease and cardiac transplantation does not stop a systemic process. It just replaces the heart. And so it's not unreasonable that somebody would either have pre-existing amyloid deposits or develop subsequent amyloid deposits after a heart transplant. And it's also not surprising that someone with ATTR wild type might develop, neuropathy. We don't, and as Dr. Karam, kind of elegantly explained, we really don't know what that background signal is because it's hard to disentangle from other causes of neuropathy at the age at which ATTR amyloidosis typically presents. But I think that the tafamidis should be an effective therapy for ATTR wild type as well as ATTR neuropathy. And right now we don't have any other options until we get the results of these other trials.
Oh, Dr. Patel, in that email, they mentioned that he was diagnosed with wild type TTR in his heart and his bladder. Do you often see with wild type the amyloid fibrils in the bladder?
Actually, if you biopsy pretty much any part of the body in patients with amyloid, you will invariably see amyloid deposits. It's just that when you have ATTR, there seems to be a predilection for developing cardiomyopathy or polyneuropathy, but the protein can be discovered in other parts of the body on biopsy. And in fact, we often use that to help us with diagnoses in patients presenting. If they've had a recent biopsy for some other type of disease, we'll often go back to our pathologist and ask them to stain for amyloid to see if there's any evidence of amyloid in that tissue. And so it can help us from a diagnostic perspective. Usually the presence of amyloid found in these other organs does not really lead to clinically significant disease. Perhaps the exception may be when it involves the bowel, particularly in patients with hereditary ATTR.
Okay, well, I have you. This person asks, does cardio rehab help? Has anyone found a regimen that is beneficial?
Well, cardiac rehab is interestingly approved therapy for patients with heart failure with reduced ejection fraction, and Medicare pays for it. But currently, it's not being covered for patients with heart failure where the ejection fraction is preserved, where most amyloid patients sit. But in general, exercise is of benefit. As Dr. Karam mentioned, exercise can benefit neuropathy, and it can certainly improve heart function by making delivery of the blood and oxygen more efficient to the muscles and the rest of the body. So I really recommend patients that they remain physically active because it can have multiple benefits.
Okay, anyone add to that before we go to the next question? Okay, we're going to make this the last question for now, and we'll hold off the rest of the questions till the end of the presentations because we have lots of them. And I want everyone to know, if we don't get to your question, I promise you, I will email them all to these wonderful doctors. And I know from past experience, they will all answer them. And then I will send you on their answers via email. So don't worry, we will get answers to all your questions. Okay. Here's one last one that we'll cover for now. And this is a heart biopsy in December 2019 confirmed my wild type diagnosis. I've been taking tafamidis ever since. I'm still stage 1. In the last year, I've been experiencing a chronic persistent case of throat clearing that can last hours or all day. Neither my ENT or laryngologist can identify a cause or even a remedy for this condition. Ibuprofen has little remedial effect. Could amyloidosis have affected my vagus nerve so as to innervate my heart and vocal cords and thereby trigger the throat clearing? Any thoughts on dealing with this are appreciated. So I don't know whether this would be a Dr. Karam question or a cardiologist question. So someone come up with an answer. Okay. Dr. Patel, we know that we hear people talk about non-productive coughs all the time with TTR and even AL amyloidosis. So I know you're going to have an answer for this.
Well, actually, heart failure is a very common cause of a cough. And so the first thing to make sure is that the heart failure is well managed. And then other causes of the type of cough that was mentioned may relate to things like gastric reflux, which may or may not be related to amyloid and autonomic dysfunction, but gastric reflux is quite a common cause for chronic cough, particularly nocturnal cough. And it looks like the ENT physician has excluded things like postnasal drip and that type of thing. Now, we have had patients who've undergone evaluation for heart transplantation, whereby they've undergone evaluation of their lungs and have been found to have some amyloid in their lungs. And of course, it's very difficult to know what contribution of shortness of breath in those situations is coming from the lungs versus the heart. And that can be somewhat problematic, but getting the lung function tested after the heart failure has been optimized may help in terms of determining what's going on. And sometimes we can pick it up on imaging, such as CT scan of the lungs as well.
Thank you. Dr. Karam, he mentions his vagus nerve. So what can you tell us about the vagus nerve in relation to this?
Yeah, that's definitely an interesting thought. And definitely the vagal or vagus nerve could be affected in amyloidosis. I personally have not seen vocal cord paralysis from amyloidosis yet. Again, I always say yet when it's something, unusual, because again, anything can happen with amyloid. I would always like to rule out common things. Dr. Patel went over those before kind of blaming everything for amyloid, because, if there's something common that can be addressed, that'd be great. If it's, let's assume amyloid in the nerve, the patient is already getting treatment. So there's, unfortunately, then we'll be won't have that many options. So let's rule out common things that can cause these symptoms. And if we don't find a cause, then, maybe we can assume that it's amyloid.
I would even just make the point that it's unlikely amyloid. ATTR wild type doesn't, Dr. Karam can correct me, does not typically cause autonomic neuropathy. And so I think peripheral neuropathy, certainly possible, but autonomic neuropathy has not been well described. And in my experience, I have not seen it. I think it's more likely something else. Dr. Patel already mentioned the key points. The other one I would just add is the obvious ACE inhibitor that someone may have started for his heart failure. And that obviously is well known to cause kind of a chronic cough that is like, is related mostly to a cause of the drug, and it stops when the drug is stopped. But heart failure, GERD, other things I think are reflux disease are the common ones I've looked for.
Wouldn't orthostatic hypotension be autonomic neuropathy?
Yes, but orthostatic hypotension can be caused by a number of different reasons, and typically in ATTR amyloidosis, it's because of low cardiac output, dehydration, and not because necessarily that there is, again, autonomic neuropathy, as you see in hereditary amyloidosis or light chain. Again, I defer to Dr. Karam as a neurologist on this call, but that's not something that I have commonly seen.
Okay.
Yeah, I agree with Dr. Ruberg. It's not common. Unfortunately, we do have some folks with autonomic failure who also have wild-type amyloid. But also the issue, again, that I have personally is that how do I prove that this is really from amyloid? Because autonomic failure also and orthostatic hypertension become more frequent as people get older and they are on multiple medications. So I think, I would not like to give a definite cause of these things at this point. I think until we know a little bit further, hopefully in research in the future will kind of help us and visualize where the amyloid is really being deposited.
Okay, well, thank you all so much. I know that we're going to be losing Dr. Ruberg, not permanently, but I know he has to go for the day. So and we want to thank you so much, and we will let you go. We're not letting Dr. Patel or Dr. Karam go, okay? And they're tied to their seats. And we will take our 5-minute break, okay? Thank you again. So now we're going to hear from Michael Maitland, okay, from Intellia. And so, Michael, take it away.
Thanks, Muriel. By way of introduction, I'm a physician scientist. I'm the medical lead at Intellia on our NTLA 201 program. We have a large team at our relatively new biotechnology company. And the focus at Intellia is, of course, on patients and the effort to bring these exciting new technologies in gene editing to patients for use in treating disease. And what we hope can fulfill the promise of revolutionary ways. The primary technologies we use right now are based on a gene editing system called CRISPR-Cas9. Dr. Ruberg told you about this a little bit earlier in the session. CRISPR refers to specific sequences that are found throughout our chromosomes near genes in your DNA. Cas9 refers to the gene and the enzyme that will recognize these sites and modify the DNA in a very specific way. And so our founder, Jennifer Doudna, co-founded the company in 2014, and she was recognized for the scientific discovery made a few years before that with the Nobel Prize in chemistry in 2020. As Dr. Ruberg mentioned, the original studies of CRISPR and Cas9 were in bacteria. Bacteria that are found throughout the planet and our bodies use CRISPR and Cas9 as a form of an immune system to protect the bacteria from viruses. The Nobel Prize was for Dr. Doudna and her colleagues and co-discoverers performing experiments that demonstrated that you could use this bacterial immune system equipment, the CRISPR and the Cas9, to edit genes in mammalian or cells from mammals like humans in a very specific and selective way. And so for now, Intellia is focused on treating diseases where there is a way to modify the genes in the liver to have a potentially major impact on a disease. And as many of you attending today are aware, the transthyretin protein that circulates in your blood and can form the amyloid fibrils of ATTR amyloidosis is made almost exclusively in the liver. And so we have developed the equipment that demonstrates that we can infuse compounds like NTLA-2001 into the bloodstream. It will rapidly migrate to the liver and be taken up by the cells of the liver called hepatocytes. And the drug can then execute the gene edits and then be degraded by natural body processes and be gone from the body. And so what this slide is just showing you is the idea that the CRISPR-Cas9 apparatus can be used to target a very specific sequence in the body, in this case in the liver, and in this case TTR, and introduce a permanent change in the DNA. In the case of NTLA-2001 and TTR, we inactivate the gene, a term that scientists technically for a few decades have called knockout. And so you can think about how NTLA-2001 might ultimately fit into our armamentarium for treating ATTR amyloidosis. If you start in the upper right corner here with the TTR protein outside of the liver cell, you heard earlier diflunisal and tafamidis can bind to the protein and help to prevent it from degrading into a form that is prone to creating amyloid fibrils or making amyloid fibrils longer. The silencer treatments, your Tegsedi, your Onpattro, and the newer generation agents, they will bind to the TTR mRNA inside the liver cells and prevent the formation of the TTR protein. NTLA-2001 gets a little bit closer to the root cause by actually targeting the gene itself and inactivating the TTR gene, and therefore disrupting this process and leading to minimal production of further TTR protein. And the assumption is that when you create these very low levels of protein, that you reduce further formation of the amyloid. There's some scientific concepts throughout amyloidosis that if you really shut down the TTR protein production to extremely low levels, that may give the body the opportunity to degrade some of the amyloid and perhaps, hopefully, ultimately improve the disease. But certainly for now, it is very clear with the silencers and tafamidis that by at least reducing the formation of amyloid, you can see a reduction in disease symptoms comparative to if you do not reduce the amyloid production and reduce the transthyretin that's causing the amyloid production in the first place. And so the excitement for our treatment strategy came to public attention last year around this time when we published in the New England Journal of Medicine a report from our ongoing phase 1 trial from just the very first 6 patients to ever receive the agent. And very gratifyingly, we were able to demonstrate that all 6 subjects had evidence of reduction of TTR protein in their circulation, and giving a proof of concept for this idea that CRISPR-Cas9 based gene editing could be used in the future to hopefully effectively treat diseases. So we're still in this phase 1 trial now. We published last year the outcome for 6 patients. We now have enrolled more than 30 patients, and we're looking forward to appropriate times in the next year as we complete the data collections and the data analysis. And we have the right opportunity to have thorough, thoughtful scientific review by folks not involved with the company to make sure that we have something useful to share with the community before it is presented by our many experienced and insightful investigators who are conducting this initial phase 1 clinical trial. I'm not going to go through the details of the trial here. A common question for Muriel and for us is regarding US citizens who have the diagnosis and can they access the treatment. At the current time, no, we do not yet have an investigational new drug license with the US FDA. The phase 1 trial is actively ongoing in the United Kingdom at a facility in London, in Sweden at the University of Umeå, and in New Zealand, in Auckland, New Zealand, with folks at the university there, also working with a clinical research facility called New Zealand Clinical Research. A key point, though, to bring up here is that the agent is similar in its basic structure to Onpattro or patisiran. And the next closest agent that is in widespread use in humans that has similar design and manufacturing is the Moderna COVID vaccine, which uses a lipid nanoparticle and carrying messenger RNA. And NTLA-201 has a similar structure. Instead of carrying mRNA for COVID protein, it's carrying the mRNA for the Cas9 protein. And I think a key point is that up front, when you're contemplating treating disease through genetics, you have to think about genetic diversity of humans on the planet. And that is something that our laboratory scientists think about from the very beginning of first designing the drugs. And so our expectation is that we will be creating agents that can have a very personalized effect, but also would be widely useful to as many patients carrying the disease as possible. And so, of course, in conclusion, I can't get more excited about our new technology without just recognizing that the decision to develop the first gene editing technology ever in humans for ATTR amyloidosis is really based on all the excellent scientific work that's been done in this field for several decades. The proof of concept for treating the disease that comes from the scientific work, both at Dr. Ruberg's institution with diflunisal, as well as the development of tafamidis by the scientists and investigators at Pfizer, and the RNA silencing treatments from Axia and from Alnylam. And so with that, I'm going to stop my presentation and let you know just that we are, of course, actively communicating with experienced investigators such as Dr. Patel and Dr. Ruberg, and looking forward to, in the years to come, bringing forward a larger clinical trial where we may test indeed whether gene editing can make this disease better than currently available treatments. So thank you for your time.
Well, thank you so much. We appreciate it. And we look forward to talking to you again in our next TTR webinar, because, and perhaps maybe, you know, you'll get very loose-lipped in Heidelberg, and that would be a great thing too. Thank you.
All right, thank you.
Okay, and next we will hear from someone who maybe can be a little loose-lipped too, Colleen Moffitt and Alnylam. Colleen?
Thank you, Muriel. I'm just going to share my screen here. Great. Okay. So this slide presents a summary of Alnylam's ATTR amyloidosis clinical trial programs. And today I would like to focus on vutrisiran, and the brand name is Amvuttra, which was recently FDA approved for the treatment of the polyneuropathy caused by hereditary transthyretin-mediated amyloidosis, or hATTR amyloidosis, in adults. Data collected up to the 9-month time point in the Helios-A study led to the FDA approval of Amvuttra. The study continued for an additional 9 months, and that data will be discussed today. After this initial 18-month time period, patients continued vutrisiran treatment for an additional 18 months at a dose of either 25 milligrams every 3 months or 50 milligrams every 6 months. That final 18 months of the study is currently ongoing. So Amvuttra is given once every 3 months as a 25 milligram subcutaneous injection by a healthcare professional, such as a doctor or a nurse. And as we go through this presentation, I'll share some important safety information, and the full prescribing information is available at amvuttra.com. And there are also QR codes on the slides that will link to the prescribing information. So as I mentioned, the safety and effectiveness of Amvuttra were evaluated in an 18-month study of 164 adult patients with polyneuropathy caused by ATTR amyloidosis in adults. The clinical study of Amvuttra focused on changes in nerve function and quality of life. The effects of Amvuttra on other aspects of the disease, including walking ability, nutritional health, and the ability to perform activities of daily living, were also evaluated. The effectiveness of Amvuttra was evaluated using multiple assessments, and these assessments were performed at 9 months and again at 18 months. Effectiveness was determined by comparing results from patients treated with Amvuttra to patients from a similar study who were given placebo. All the effectiveness results I will share with you today reflect a comparison between these two groups. Amvuttra treated patients showed significant improvement in nerve function and quality of life at 9 months and continued to improve throughout the 18-month study compared with those who received placebo. Nerve function was assessed using a scale called mNIS+7.
Is your slide supposed to be changing because we're still on the?
No, this is I have 3 slides all total.
Gotcha.
Okay. So we'll go back to nerve function, assessed using a scale called mNIS+7 that measured strength and sensation in the hands, feet, arms, and legs, in addition to reflexes and blood pressure upon standing. Quality of life was evaluated using the Norfolk QOL-DN questionnaire that asked patients about the severity of their polyneuropathy symptoms, how often they experienced them, and what impact they felt these polyneuropathy symptoms had on their daily lives. Results from the study were evaluated to determine how many patients regained some nerve function or reported better quality of life from the start of treatment. So at 18 months, 48% of Amvuttra-treated patients regained some nerve function from the start of treatment, compared with 4% of those who received placebo. For the patients who received Amvuttra and did not regain some nerve function, progression of their neuropathy was slowed compared to those who received placebo. 57% of Amvuttra-treated patients reported better quality of life from the start of treatment, compared with 10% of those who received placebo. The effects of Amvuttra on other aspects of the disease, including walking ability, nutritional health, and the ability to perform activities of daily living, were also evaluated at 18 months and compared with the effects of placebo. Amvuttra-treated patients maintain a better walking speed compared with patients who received placebo. This was evaluated using the 10-meter walk test, a stopwatch timed measure of a patient's walking speed over 10 meters. Amvuttra-treated patients experienced improvement in nutritional health compared with patients who received placebo. This was evaluated using the modified body mass index, an assessment of height, weight, and the balance of fluids in the body. And Amvuttra-treated patients were better able to perform common daily activities compared with patients who received placebo. This was assessed using a 24-item questionnaire called RODS, in which patients rated their ability to complete tasks at the beginning of the study and at the end of the study. Common daily activities included showering, brushing teeth, dressing upper body, going shopping, doing dishes, and walking up a flight of stairs. So for patients taking Amvuttra, treatment with Amvuttra lowers the amount of vitamin A in the blood. And your doctor would tell you to take a vitamin A supplement every day. You should not take more than the amount of vitamin A recommended by your doctor, and a low vitamin A level can affect vision. And if you have problems in your vision, such as night blindness while taking Amvuttra, talk to your doctor, who may refer you to an eye specialist. Side effects include unfavorable symptoms or conditions and laboratory results outside of normal range that occur or worsen because of treatment. The most common side effects of Amvuttra are pain in the joints, arthralgia, shortness of breath, dyspnea, and low vitamin A levels. These are not all the possible side effects of Amvuttra. Again, talk to your doctor about side effects that you experience. And you're encouraged to report negative side effects of prescription drugs to the U.S. Food and Drug Administration. As I mentioned, Amvuttra is given once every 3 months as a 25 milligram subcutaneous injection by a healthcare professional, such as a doctor or nurse, and talk to your doctor if you have any questions about treatment with Amvuttra. And I'll close with that, Muriel, and answer any questions.
Thank you so much, Colleen. We do have a lot of questions in regards to Amvuttra, but I would like to save it till after the other presentations. So now next, we will have Gustavo Buchele from Ionis.
Good morning, good afternoon. Let me share my screen with you guys. Perfect. Can you see my screen?
Yes, thank you.
Thank you very much, Muriel, for having us here. Thanks for all the presentations, they're very nice. So today, briefly, I'm going to talk about the Transform program from Ionis. And now, as you may know, with AstraZeneca joining us for future commercial activities, if these drugs are properly launched and registered. So we're going to have more partners and increasing the family for this compound. So let me talk a little bit about the Transform program, how we are going. So as you know, we have the Neurotransform trial that it's focused on eplontersen for the patient with ATTR polyneuropathy. And also we are running the Cardiotransform trial, the same plans for patients with cardiomyopathy secondary to the ATTR amyloidosis, both wild type and hereditary. And of course, we have a plan for interesting life cycle management of this compound if it's approved, considering other interesting populations to study that, of course, we're going to disclose at the proper moment. I think the news we have for this meeting today, it's about the Neurotransform study, which is the study from Ionis, where we are using eplontersen in ATTR patients with polyneuropathy. It's a very similar design. It was the TTR study for inotersen in the past, quite similar from what the competition Alnylam with Helios-A has done as well. And we have our eplontersen drug used in 144 patients, and the inotersen as an active comparator here, despite the trial is a placebo control, historical control, also some patients on inotersen. And what we have recently disclosed publicly is the general results of the interim analysis that was done after 35 weeks of use of the medication in all these patients that finished the period at this time. And as you know, the results in general were very positive. So we see here clearly achievement of the primary endpoint, exactly what is expected for this moment in both the neural function, the mNIS+7, as well known by you guys, and also in the quality of life measurements, the patient-centric way of looking for these improvements. Of course, I think we're all very curious about the details, how much were these changes, how the graphics talks to these results, but we still don't have all that ready. Our key opinion leaders, most of them you know very well, are helping us in understanding the results, and it will be presented on the ISA meeting in Germany now in early September. We should have all the details for you. So it is a very interesting moment for us. I remember several months ago when our colleagues brought Helios-A results, very optimistic for the future treatments for these patients. Now it's one more with great results, and we are sure the data will be very, very compelling. I expect you to be paying attention of this when we get for the ISA. Everything happens properly, we should move to a potential launch of this molecule. The sooner the better, depending on how FDA gets to our submissions. Of course, don't have necessarily proper dates for that, but we are working on. I think the main point also for this compound here, for eplontersen, is talk about the safety, which was one of the important points for this trial and this program for us. And I can tell you again, in the general numbers, that safety was not an issue for this trial. The adverse events of interest that were a concern for inotersen in the past were not a signal at all in this program. So very soon you're going to have all the results, and I hope this is going to bring more optimism for the future treatment for these patients. And very briefly, just remind you the CardioTransform trial where we are using eplontersen, but now in the patients with the cardiomyopathy phenotype, both wild type or hereditary. This is the largest study on cardiomyopathy ever tried, I would believe. We have more than 1,000 people in the study. And we will be still enrolling, so we're still open for enrollment in several sites in the United States and Canada, and also in Europe, Latin America, Australia, and some areas of the Middle East. So this trial is still ongoing. We don't have an expectation to stop enrollment soon for now. So we hope also to, with this trial, bring a lot of light on the future treatment with the silencers. I think this was all my information, Muriel, and I'll be glad to take questions if you guys have any. Thank you very much.
Thank you so much. Yes, we do have questions, but we're going to let them wait until after our last presenter. Okay, so hang around. You're not allowed to leave. Okay, next we're going to hear from Pfizer. We have Craig, Chris, Joe. I'm not sure who's going to do the presentation.
Chris and I are going to be presenting. I'm going to hand it over to Chris to provide an overview of Vyndamax, and then I'm going to have a quick overview of the new website we've just launched. So Chris, it's all yours. You know what? Why don't I give you a quick update on a website, and then we'll hand it over to Chris if he's able to take care of those technical difficulties.
Sounds good.
Yeah. So, hi everyone, great to be here today. I'm excited to announce the launch of our website, togetherforrare.com. It's a new resource for patients and caregivers. Togetherforrare.com replaces the online form you may be familiar with, PfizerPal.com. On togetherforrare.com, you'll find a short video. It's approximately 3 minutes long, and it describes the role of a Pfizer patient affairs liaison and how they support the advocacy patient and caregiver community. Patient affairs liaisons work with patients and advocacy groups to better understand the needs of rare disease communities. Patient affairs liaisons, PALs for short, provide educational information on Pfizer programs, serve as a contact for local patient advocacy groups, and answer questions from patients about certain programs available to them. If you are interested, you're going to find a registration form on togetherforrare.com if you would like to connect with a Pfizer patient affairs liaison in your geographic location. By completing and submitting this online form, a patient affairs liaison can contact you regarding patient caregiver educational programs, resources, and information relevant to ATTR-CM. And Pfizer may email you with educational information about ATTR-CM and educational information relevant to living with a rare disease generally. And if you would like to connect with the patient affairs liaison, you have several options to do so. You could connect through email, phone, or Zoom, whichever option meets your needs. Also, on togetherforrare.com, you'll find many resources, for example, ATTR-CM disease education digital downloads, a link to a website, yourheartsmessage.com, where you'll find information about ATTR-CM, a doctor discussion guide, and educational resources. And you'll also find a brochure about patient affairs liaisons, which you can download. So if visiting togetherforair.com is of interest, I'd suggest starting with viewing the very short video, it's about 3 minutes long, about the patient affairs liaisons, which you could find on the homepage. And with that, I will hand it over to Chris to see if he's taking care of those technical difficulties.
Hey, Craig, can you hear me?
Yeah, all good.
Okay. So I'm dialing in from my phone, so I apologize, but if you can hear me okay, I'll get started. So my sincere apologies. My name is Chris Olson from Pfizer, as Craig mentioned, and again, we're honored to participate in today's webinar, and thank you again for the invitation and opportunity. As mentioned in the earlier sessions today, there are programs that help support access and reimbursement for patients who have been prescribed Vyndamax, and I'm incredibly excited to discuss Vyndalink with you today. Please remember, you can always visit www.vyndalink.com for more information on support and resources. But at Pfizer, we are dedicated to supporting medication access and are committed to supporting individuals who have been prescribed Vyndamax by helping you access your medication and offering additional assistance and resources that may help you with your treatment journey. Please note, the same Vyndalink support offerings available to patients prescribed Vyndamax are also available to patients who are prescribed Vyndaqel. Once you've been prescribed Vyndamax, Vyndalink can help you understand your insurance coverage, connect with financial assistance resources for which you may be eligible, and identify third-party resources for additional support. Please keep in mind there are multiple ways to obtain Vyndamax, including specialty pharmacy options that are available to you, and you can discuss these options with your healthcare provider. But let's touch on a few of the Vyndalink offerings today. So first would be benefits verification. So this determines your insurance coverage, including out-of-pocket costs and payer coverage requirements, financial support options for eligible individuals, specialty pharmacy coordination, and additional support during treatment, which includes patient support navigators that can help identify resources based on your individual needs. Vyndalink can also help identify financial assistance resources for which you may be eligible. So regardless of the type of insurance you have, or if you have no insurance at all, we may be able to help you find support to manage the cost of your medicine. We can also help you better understand your coverage and benefits, including pharmacy benefits. For Medicare or government insurance patients, if you have Medicare or Medicare Part D or other government insurance plans, we can help identify financial support options that may help cover the cost of your medicine. If you have commercial or private insurance or employer or private coverage, including coverage purchased through a health insurance marketplace, you may be eligible for resources to help cover the cost of your copay through our copay assistance program for Vyndamax. We can also help identify potential resources for patients who have no healthcare coverage. So if you don't have healthcare coverage, we can connect you to potential resources that may help cover the cost of Vyndamax. And lastly, Vyndalink can help determine which pharmacies align to your specific insurance coverage, as just outlined. Most patients will receive Vyndamax, their Vyndamax prescription in the mail. And again, honored to be here. Very, very appreciative of the invitation. Thank you again for the time today, and I'll pass it back over to Muriel.
Thank you so much, Chris. And thank you for leaving the video on, so we got to see you too, which was really nice. Thank you. And next we have from the University of Tennessee to discuss imaging, Dr. Jonathan Wall. And Dr. Wall, are you there? You are. And you don't have your kitchen wallpaper up there.
No, I don't have my kitchen, and this is very impromptu. So I will get the talk up. So I'll be talking about the imaging study that we've been doing, and on behalf of the University of Tennessee Graduate School of Medicine. And so this is a study of a protein that's now called ATTR1. It's been licensed to Atralis Inc., and it's a diagnostic imaging agent for the detection of systemic amyloidosis. I have the following disclosure. I am a founder and shareholder of Atralis, and also worked on the development of this peptide. So what we came up with was a a synthetic peptide that has the ability to bind all forms of amyloid. And I'll talk specifically about TTR here. But amyloid deposits are complex. They're not just fibrils on their own, but they also contain many other proteins and some sugars. And these sugars are fairly unique, and these sugars are present in all types of amyloid, regardless of whether it's AL, TTR, or the rarer forms. And these sugars are very highly negatively charged. And so what we did was make a peptide that was very positively charged. And after many, many years of development and refining this, we were able to demonstrate that this peptide could bind specifically not only to the sugars that are in all forms of amyloid, but also the fibrils themselves. So this makes the peptide a pan-amyloid imaging agent when it's made radioactive. And the way it works, you can see in the mode of action picture, the peptide, when it's just floating around, has no structure whatsoever. But when it encounters amyloid, it starts to spiral up, form what we call an alpha helix, a helical structure, and then all the positive charges on the peptide bind to all the negative charges on the sugars in the amyloid and the fibrils themselves. And that's what gives us the specific binding. And what we can do with that is that we can make this peptide radioactive by adding very easily a molecule that has a high radioactivity output. And then we can use this peptide when it's radioactive to get images of amyloid in patients. So I'm going to talk about the results of this investigator-initiated study that we did here at the University of Tennessee Graduate School of Medicine in Knoxville. We enrolled 57 subjects from all over the United States, and they were evaluated, and all of them completed this PET-CT imaging trial. PET-CT is a clinical method for imaging radioactive molecules, mostly used in cancer, but we exploited it here as well. As part of the recruitment, we had 25 AL patients. We had 20 ATTR patients. In total, 15 of them were variant and 5 were wild type. We also had 5 other very rare sort of forms of amyloidosis. We had 5 healthy subjects, which we did later on in the trial. And then we had 2 subjects that we imaged, but the images weren't great, so we excluded them from any form of analysis. The first 3 patients we used to calculate the safety and look at the radiation dose that the patients would get. And then after that, all the subjects were dosed with 2 millicuries of radioactivity and 2 milligrams of peptide. And all the patients were imaged also about 5 hours post-injection. The images were all read by a radiologist, a nuclear medicine pharmacist, by one person, and he had no idea what patient had what disease, so he was blinded to it. And we were able to look at, determine cardiac uptake, especially. I'll focus on that in all the subjects that were enrolled. And then we did safety follow-up by phone calls at day 9 and day 28. So by way of some early results, we have what we call the patient-based sensitivity. So everybody we enrolled, apart from the 5 healthies, was known to have amyloidosis. And we came up with an outcome measure called patient-based sensitivity, which basically says, of all the patients who are known to have amyloidosis, how many of them did we see imaging uptake of the tracer in any organ whatsoever? And that was 96%. So 48 out of the 50 amyloid patients had a positive scan. We had 1 TTR patient who was diagnosed with systemic amyloidosis because of Congo red positivity of tissue obtained from a laminectomy, and also had some peripheral neuropathy, but they were negative. And we also had 1 AL subject who was negative. With respect to the ATTR cardiac sensitivity, though, this is patients with ATTR where the physician knew there was cardiac involvement. So these are cardiomyopathy patients. And out of 11 of those patients, all 11 had uptake of AT01 in the heart. We also saw AT01 in other organs throughout the body, kidney, liver, spleen, lungs, pancreas, and I'll show you some images of those also in TTR patients. Of the 5 healthy volunteers we looked at, not one of them had any cardiac uptake of the tracer at all. It's a small cohort, but there was no uptake in the healthy hearts. And the adverse events were mild and were transient in the subjects that we looked at. So these are images of the healthy volunteers, just to show you what sort of background looks like. When we inject the peptide, it gets cleared through the kidneys. And what happens there is some of it gets into the bladder, which is the large area you can see down at the bottom there. And then some of the radioactivity gets stripped off during that process, and it goes back to the stomach and in the glands in the neck, some of the thyroid, and then you can see some saliva as well. So this is what background looks like, and everybody we imaged had this kind of sort of background visualization. And on top of that, we could see other things in the patients. So these are 3 patients who were diagnosed with ATTR cardiomyopathy. And what you can see is the characteristic uptake in the heart, a horseshoe shape. That's the left ventricular wall. That's the thick side of the heart that pumps the blood around the body. It contains the most amyloid when there is amyloid present, because it is the thickest part of the heart. And then you can see what I showed you before, some background radioactivity in the stomach of each of these patients, as well as in the bladder in most of them. We were able to discern very, very easily the uptake. And the patient on the right, you can see not just the left side of the heart, but also uptake in the right side of the heart in these PET-CT images. This is a group of images of the heart as well. So now we're looking across the patients, and you can see in the first 3 on the left, the healthy subjects, the arrow shows where the heart is. There's no uptake whatsoever in the healthy volunteers. And in the middle panel, you can see patients who were known clinically to have cardiac involvement, and they also had uptake of ATO1 in the heart. Again, characteristic sort of horseshoe shaped for the left side of the heart. And then if there's right side involvement, you get this sort of extension of the horseshoe to the top there. So all positive. But what was interesting was we also saw uptake of ATO1 by imaging in patients who were not known to have clinical involvement by any measure, biomarkers, echo, or PYP imaging. And so we were able to detect what we think is pre-symptomatic, very early deposits of ATTR in patients using this imaging agent. This is one such subject. This is a patient with variant TTR L58H mutation. His NT-proBNP, the biomarker for cardiac function, was normal or on the edge of normal, certainly normal for his age. And we did an ATO1 imaging study on 5/2019, and we showed positivity. The same patient went for a PYP scan 3 months later and came back negative. But his treating physician was very suspicious and thought he still may have cardiac amyloidosis. So he was sent to the Mayo, and after having an endomyocardial biopsy at the Mayo, that came back positive. And so this is an example, just one, of a patient where we were able to detect uptake of ATO1 in the heart muscle, which we think is associated with the amyloid in the heart that PYP couldn't see 3 months later, but was proven by endomyocardial biopsy and tissue analysis. Muriel asked me to talk about some of the extra cardiac findings we've seen using ATO1 in patients with TTR. In patient 1, in patient 1 on the left, the arrow with the L points to what we think is lung uptake. That was not very common, but was observed in quite a few patients with ATTR and also AL. This patient also had heart involvement. The patient number 2, this is a rare mutation. This was an F33I with amyloid in the vitreous humor. But on imaging, we were able to see uptake of ATO1 in the fat around the neck. That's the F. We also saw it in the kidneys and this patient's pancreas, as well as in the heart, where we were suspecting. So very diverse uptake of ATO1 in this patient. This patient knew he had obviously TTR amyloidosis, and he had a positive abdominal fat biopsy based on Congo Red. So he was suspicious that he had sort of amyloid in other organs other than the vitreous humor, and the imaging agent sort of demonstrated that. In patient number 3, you can see what we see quite often in TTR patients where there's joint involvement. You can see the shoulders in patient 3 lighting up. This patient, we often see hip and joint uptake of ATO1 in TTR patients. Sometimes it's equivalent in both shoulders, both hips, both wrists, but in others it can be dominant in one or the other. In patient 4, you can see very high uptake in the subcutaneous fat and abdominal fat in this patient. So the idea being that there may be TTR amyloid deposits within the fat in these patients as well. And we know that in some patients we get abdominal fat positive biopsies, so that was perhaps not surprising. And in patient 5, you can see very distinct uptake of the radiotrace ATO1 in the spine of this patient with TTR. Again, a common feature of patients is laminectomy surgeries due to spinal stenosis, and you also get sort of joint and bone and involvement in the spine. So we were able to see that in quite a few patients as well. So a very diverse presentation of TTR. And that was mentioned earlier When you look in any organ in a TTR patient, you can see amyloid if you look hard enough. But with this imaging agent, we're able to appreciate the larger deposits in these different sites other than the heart. Muriel asked me to talk about nerve uptake. So in one patient, we did leg imaging. Well, we did leg imaging in lots of patients, but in one in particular who had crippling polyneuropathy in the leg and was wheelchair bound, had an L58H mutation. And because of muscle wasting in the legs, we were able to see, this is the CT scan, where you're just looking at the muscle and the nerves. And when you overlay the PET image, there is suspicion that there's uptake in certain of the nerves or certain of the regions that could be nerve in this image. It's very difficult in the legs using PET-CT to ascribe radioactivity specifically to the nerves in the legs, because it's not, CT is not a great modality for discriminating nerves from blood vessels, and blood vessels run right next to the nerves through the leg. So this is the only example where we were very, very suspicious that we had nerve uptake. And in this gentleman, the neuropathy and probably the amyloid in the leg was very extensive, which may have allowed us to do that. I think we would need a different protocol and maybe a different imaging system to look for specific uptake in nerves and be confident that we were able to image it. But this tracer binds amyloid, and if there's enough there and using the right protocol, we're very confident you should be able to see it. So with respect to summary for the ATTR patients, as I mentioned, we did 20 ATTR patients, 11 had cardiomyopathy and 9 were diagnosed with polyneuropathy, 15 variants and 5 wild types. 9 out of 9 patients who had an elevated NT-proBNP had positive ATO1 in the heart, so 100% accuracy at that point. 5 out of 5 patients who had a positive PYP scan also had uptake of ATO1 in the heart. So we were correlated well with the PYP scans. But what was interesting was that in 6 of the 9 patients diagnosed only with polyneuropathy, we were able to detect ATO1 uptake in the heart, which perhaps is not surprising. These patients, TTR patients will, I mean, the deposits are not specific for one site or the other, but the symptoms that appear first differentiate sort of which category you fall into, but there's no reason to suspect that the TTR is not present in other organs. And so we found that in 66% of our TTR patients who had polyneuropathy. 8 of 11 patients who had normal NT-proBNP also showed ATO1 uptake in the heart, and I showed you that one patient where it was demonstrated by biopsy that there was amyloid there. And 4 out of 5 patients with a negative PYP scan also had uptake in the heart. And this is a small early study, but the data suggests that ATO1 might be able to pick up early deposits before symptomology occurs and before other methods of imaging are able to detect them. And so that's very exciting for us. So with respect to the status of ATO1 development, we've completed successfully the phase 1/2 here in 57 subjects in Knoxville. And now there are ongoing studies. There was a phase 2 retest study that was performed on the West Coast, and enrollment has completed there. There's an ongoing study at Brigham and Women's run by Dr. Dorbala. She's looking at ATO1, comparing it to florbetapir, which is an A-beta Alzheimer's amyloid brain imaging agent. And she's comparing ATO1, looking at cardiac amyloid patients with AL and ATTR, and that's ongoing. And Dr. Matt Maurer in Columbia is about to start an ATO1 study in transthyretin cardiac amyloidosis, looking for early detection as one group of patients, looking for cardiac involvement in very rare variants where PYP imaging might not be as robust as it is in the general population, and also looking at quantification of this extra cardiac amyloidosis and seeing what that means clinically for the patients. We are planning to do, or Tralis is planning to do, a study in cardiac amyloidosis in ALTTR and other patients, and they're also planning to use it in their therapeutic trials of pan-amyloid removing agents in 2023. This is the group of folks at the UT Medical Center in Knoxville who helped us do this study. And with that, Muriel, I shall end my talk.
Well, thank you. That more than met our expectations. That was wonderful. Thank you so much.
You're so nice.
No, really great. I appreciate it so much. And we we didn't, you don't know what you don't know. So we don't have too many questions for you because we didn't know what you were going to present, but I have a feeling they'll be emailed in now. So I'll just forward them over to you and you can attempt to answer them, okay?
Yes, ma'am, my pleasure.
Okay, super. If we could have all of our physicians and pharma folk up, on the screen here, we've got some questions. Of course, lots of, the elephant in the room is the Amvuttra drug. So we've got lots of questions about Amvuttra, okay? We do have one here about Vyndamax, okay? And this would be answered by, our Pfizer people and also our cardiologist, perhaps. My husband is 82 years old with wild type. He also has aortic stenosis and Parkinson's. The doctor has him on 20 milligrams of Vyndamax. The VA will not authorize the 80. Will the 20 milligrams be giving my husband some help? So we'll go to Dr. Patel on that. Okay, Dr. Patel, what do you think?
Hi, Muriel. My understanding from my VA colleagues is that the VA has recently changed its stance on the dose of Vyndamax for patients with cardiac amyloidosis, and based upon the long-term extension data that was recently made available. And my understanding is that the VA patients are able to get the full dose now, or will soon be able to get the full dose as a result of that.
Well, that's good news. Okay. Craig, do you know anything about that, or would that just be someone else at Pfizer that might know that?
Right. So certainly we'll work with medical information and provide the latest to you, Muriel and Paula, that you can then share with the community.
Thank you so much. So we'll let people know about that. Okay. Also, this is for you, Dr. Patel. The same person. Also, we are seeing two cardiologists, one at the VA and one at UW. I'm going to guess that's the University of Washington, but I don't really know. Okay. They being the VA, feel we should only see one. What is your opinion? Dr. Patel, let's ask your opinion.
I have a number of VA patients that I see in my amyloid clinic in conjunction with the VA. The reason for patients being seen at the VA is really so that they can get tafamidis at a much lower copay. The VA has a standard copay for all their drugs. And so it can be a lot more affordable for patients to go to the VA. Now, whether the patient needs two cardiologists or one really depends on whether the VA has a dedicated amyloid center for management. And this may not always be the case. In Los Angeles, we do happen to have a VA physician with expertise in amyloidosis. But nonetheless, I still see those patients in conjunction, because many of the clinical trials that are available at our center are not available within the VA center. So I think it does depend upon the region as to whether you need to see both cardiologists or not. In fact, actually, if you outside the VA, most of my patients are referred by general cardiologists. And so those patients continue to be seen by their own cardiologists in conjunction with me. So it's not uncommon for amyloid patients to be seen by two cardiologists.
There you go. Okay. And we know a lot of our patients are seen by two. They have their local doctor, like you say, and then they have the doctor at the center where they have all the clinical trials. So we're all for getting two doctors. And that sounds great. Thank you. Okay. Here's another person on tafamidis. So I don't know if this is tafamidis related or whatever. So we'll ask. I'm 82 with wild type TTR and on tafamidis. I've experienced the last few months post-nasal drip during the night's sleep. There's a resulting feeling of congestion that disappears after moving around in the morning. Any connection to wild type TTR or connection to tafamidis? So Dr. Patel, what do you think?
Sorry, you got cut out there. Could you repeat that?
I'm 82 with wild type and on tafamidis. I've experienced the last few months post-nasal drip during the night sleep. There's a resulting feeling of congestion that disappears after moving around in the morning. Any connection to wild type TTR or tafamidis?
As Dr. Ruberg mentioned, the side effects to tafamidis are actually exceedingly rare. I probably only have 2 patients that have not been able to tolerate tafamidis. And usually it's, in the 2 patients I had, one had a rash and the other one just didn't feel generally unwell. So I've not had any patients develop the type of symptoms that are described. However, those types of symptoms can be associated with other treatments for heart failure that may have been prescribed at the same time. So it'd be important to kind of review those other medications and see if those may be contributing to those symptoms.
Okay. Here's a person with hot flashes. Okay. I have significant hot flashes daily. This has been going on for years. Could this be related to the disease itself or more a side effect of patisiran? It seems worse than starting patisiran 2 years ago. Okay. Dr. Karam, have you heard anything about that hot flashes perhaps in your practice?
I have not, no. I mean, sometimes during the infusion, we get all kind of side effects. Most time are related more to the steroids, and over time we do tend to reduce the steroid, but I have not had anybody with this kind of hot flashes continuously. No.
Okay, thank you. Okay, Gustavo, are there any trials available for us with wild type amyloidosis in the United States where we can stay on tafamidis?
Yes, that's a great question, Muriel. So the CardioTransform trial for the patients with cardiomyopathy, it's a trial that accepts tafamidis at any time per the discretion of the physician, no questions asked. So in our trial, all patients are free to use or not tafamidis as they wish. So United States now, we have been closing the enrollment of wild types in most of our centers, just focusing on hereditaries now. We're closing to, accrue all the patients we need, but we still have, I would say, probably 5 or 6 sites in the United States where you can be potentially enroll in a trial, being a wild type cardiomyopathy patient on tafamidis, no problem at all. So I think in the contacts that we provide for more information about our trial, the patients can find out which institutions are still open. And I believe they will be open for sure the whole year, maybe over next year sometime. So you have time to look for.
Can you send me an email with those locations where it's still open and where the wild type can do that? I imagine if you go to clinicaltrials.gov, it's going to list a whole bunch of locations, and we wouldn't just want to limit it to those that are open.
Absolutely. That I actually should know all this by heart, but I'm not going to try because I might miss someone, and that's not nice. I'll send you immediately. You're going to have it to share with your colleagues. And yes, this should be very clear.
What are the benefits of receiving Amvuttra injection compared to the Onpattro infusion? Wow. How long will I have to be on the Amvuttra injection? Why are the veins in my arms, hands, legs, and feet more visible? My veins are protruding. Is it because my skin is becoming thinner due to age or my amyloidosis or both? Boy, that's a lot of questions there. So Dr. Karam, I think we'll have to bring you in on some of that. But let's, what are the benefits to receiving the Amvuttra compared to Onpattro? Dr. Karam, let's ask your opinion on that.
Yeah, so I mean, the obvious is that one, you don't have to premedicate. I mean, with Onpattro, you have to premedicate people. Number 2, it's a subcutaneous injection. Number 3, it's every 3 months. So I think it's an ideal, method of administration. So I think these are really the, and the idea is that, and the study has shown that the effect on the TTR protein is similar, maybe slightly better, and so it should work as well as Onpattro. So I think it's better than Onpattro, and I have many patients probably that want to switch. Maybe most of the patients would want to switch because you don't have to do that infusion anymore.
Do you wait for the patient to bring it up to you to switch, or are you bringing it up to them?
If they give me a chance, I'll bring it up to them. But most of the time, people, they are aware of what's going on, and they want to switch. But I do offer, I do try to update people on what's going on every time we meet.
Okay. Let's see. Okay, we had several questions. Okay, and this would be, I guess, for Gustavo and Colleen on your drug that is in clinical trials for cardiac. Okay, and they all are asking, when do we think that's going to be presented to the FDA for approval? Because our wild type people want access to that drug. So what is your answer, Colleen? And then I'll ask Gustavo. Okay, Gustavo, thank you so much. Gustavo?
No, I think that as we've been discussing here in this forum, our program in comparison with the Alnylam is around 9 months a year behind. So I think we should have, as I said before, we have the largest trial for cardiomyopathy, and now in the most recent amendment, we are going over 1,000 patients. So this has changed recently a little bit of our timelines. But responding to your question, we have a great chance to have a readout of the results by the end of 24, and then potentially, if positive and everything goes okay, to have a launch somewhere in 25. But this is like a stretch goal, which we are very confident, but it's a stretch goal. The trial should finish, as I suggested before, 1 year later, what we used to see from the Alnylam colleagues. So that would be by 25, potentially a launch on 26. That's the natural. But as I said before, we believe, cannot promise anything here, but we believe we have a good chance to have a readout by the end of 24. Let's see how it goes.
Thank you. Okay, you've all been great. And I have more cardiac questions and more neuropathy questions and lots more questions for everyone, but we're already a half hour late and we haven't heard from Paula yet. And she's going to also tell you how to save the chat, because I know there's a lot of good information in the chat. So next we'll go to Paula, and what we'll do is I promise you I'll email you all these questions and I will expect answers within 48 hours, because they will hound me if I don't give them answers, and I'm afraid. So make sure you get back to me. Okay. Thank you so much for all you've done for all of our patients. We appreciate it so much. Thank you for coming today. And Paula, you're on next.
Thanks so much.
Hi, everybody. I had gone ahead and put most of my presentation in the chat box, the information from it. In order to save the chat box, if you go down to the bottom of your viewing screen, basically right below my face, you will see a place that says chat. Open the chat box if you don't have it open already. Just click on that. It will open the chat box. And if you look on the bottom right-hand corner of the chat box, you will see some little icons. You'll see what looks like a little sheet of paper, then a smiley face, and then 3 dots. If you click on those 3 dots, you can, at the top of the list, click Save Chat. And it will save all that information that I've entered in here for you somewhere on your computer. Now it's going to ask you possibly where to put it. So you're going to have to pick a place on your computer or your phone where you can go back and find this file. So make sure you put it somewhere you can find it, or else just write down whatever name it shows up that it's giving it. But it may show up in downloads. It may show up in a folder if you place it in one. So just be sure to look at that. But right now, there is not any financial assistance open that I was able to find through the foundations that we have available. The best thing that you can do is to go to the links that I put in the chat and sign up for the notifications that you can receive from each of the different foundations that give out money. You've got HealthWell, Pan Foundation, and let's see, another one that I can't think of off the top of my head. The assistance fund. Those are the funds that normally give out money each year. The Health Well Foundation has been the most active this year in giving out funds. I don't know if they will reopen again for the rest of this year or not. They've opened up several different times and been open for about a week at a time, possibly. But you want to be ready to jump on those emails when you get them. Don't wait around. Jump on it then. If it says they have money available and you need a grant to help cover your costs, contact them. Sign up for their waiting list, sign up for their notifications. So you'll receive an email that says this fund is now open. That's how I do it. I get those notifications. And then I'll generally post it out there to our Facebook groups that, hey, HealthWell has funds available right now if you've had a grant with them before, or if you're a new patient, there's funds that you can apply for now. So just sign up for those waiting lists, and notifications is the best thing I can tell you to do right now. One thing that has not been discussed at all today is genetic testing. Bob, if we could actually go backwards on that, I'm sorry. But genetic testing, free genetic testing is available. Keep going, there you go. From two companies, we have Alnylam Act and ATTR Compass. If you have someone in your family that needs to have genetic testing done, or if you're a person that is thinking you might have familial amyloidosis, you can go to either one of these companies. Your doctors may know about it. If not, tell your doctors about it. They have to actually sign up for this through Alnylam's program. You can actually call them up directly and tell them that you don't have a doctor that will sign off on this for you, and they will assign you a person that it's actually a genetic counselor that will help you get the ball rolling on it. When the results come in, that person will contact you and give you the results. So you will have a medical person giving you the results of your testing. But they're both great programs. Take advantage of them. You know, we have some families with a lot of people in the family. So, you know, it can save you some money to use these free programs. But if you could fast forward back again, please, Bob. Let's go to the right there, the financial assistance thresholds. Back one, sorry. If you are trying to qualify for some of the financial assistance funds, they generally will have you give them, you have to give them your income levels, and they will go by basically this chart, or one much like it, that gives you the percentage of the Federal Register National Poverty Guidelines. Most of them, it's either 400 or 500% over the federal poverty guidelines that you can be and receive assistance from them. So that just gives you an idea of the dollar range that you can be in and still possibly qualify for financial assistance when it is open. But basically that's it. You know, just download the chat. That's the best thing you can do. That'll save all your links for you. If you can't figure out how to download the chat, you can also email me and I can send you that file. You can just contact me at paula@amyloidosissupport.org, or you can find me on any of our Facebook groups, and I can send you the file from the chat as well. So thank you, and I'm glad you were able to attend today.
Thank you, Paula. You're a goddess. Okay. I would imagine now with inflation, maybe those amounts might be readjusted, because that was from January. Maybe they'll go up a little bit.
They may have. I haven't looked for that. They generally do it once a year, but this year, since inflation has been so high, I may go back and revisit that and see if they have adjusted it. It also can vary according to the locale where you live. If you live in New York City, it costs you more to live than it does for me here in South Georgia. So you will get an adjustment with where you live as well.
Okay, thank you so much. And thanks so much to our panelists and our presenters and our attendees. Bob will make sure that this recording will be on the YouTube channel and our website. It's been running about 2 to 3 weeks. So, you know, as soon as we have it, we'll let you know, we'll share it. Also, One Amyloidosis Voice will have it on their website as well. So until then, please stay safe. And we're always just a phone call or an email away. Keep those phone calls earlier in the evening. Thank you. And don't forget the survey and stay safe and take care, everyone. Thank you, everyone.